Good morning. I would like to welcome all of you to this diabetes update for medical officers organized by the Sri Lanka College of Endocrinologists, Sri Lanka Diabetes Federation, and Directorate of Non-Communicable Diseases of the Ministry of Health, and also the Sri Lanka Diabetes and Cardiovascular Disease Initiative. So as all of you might be aware, November 14th is the World Diabetes Day, and access to diabetes care is the theme for this year. And to mark this event, there is a series of events that is organized in collaboration with the collaboration of all these organizations. So today is the first such event, which is diabetes update for medical officers, and we believe that this will be a very important and fruitful session to improve and enhance the knowledge of medical officers to improve diabetes care in Sri Lanka.
To mark the commencement of the event, let us first start with the traditional oil lamp. So let me introduce first Dr. Chaminda Garusingha, President of the Sri Lanka College of Endocrinologists, and Dr. Manilka Sumanatilaka, Chairman of Sri Lanka Diabetes Federation, and Dr. Chandrika Subasingha, Secretary of Sri Lanka Diabetes Federation, and also to represent the senior registrars, Dr. Neomal De Silva, Dr. Preeti Disanayaka, and to Dr. Supun Vijayawardana to light the traditional oil lamp.
To deliver the welcome speech, I would like to invite Dr. Chaminda Garusingha, consultant endocrinologist and chairman of the Sri Lanka College of Endocrinologists, to deliver the welcome speech.
Good morning, everyone. I am representing Sri Lanka College of Endocrinologists. As you know, we had Endocrine Society of Sri Lanka since 1979, and that was transformed into a college called Sri Lanka College of Endocrinologists. Then after that, we changed. After changing into the college, we thought we should have a separate body to promote the concepts of diabetes care and the educational activities among ourselves, amongst doctors and the public. So for that purpose, we formed SLDF, for Sri Lanka Diabetes Federation. And I must first of all thank the organizers, the chairperson of that SLDF, Dr. Manilka Sumanatsilaka, Dr. Chandrika Subasinghe, Neomal, and the senior registrars for organizing this event. And as you know, World Diabetes Day is commemorated every year with different themes. So this time the theme is access to diabetes care, which actually is not so bad when it comes to a country like Sri Lanka, because you all are there everywhere. And I'm very glad to see that there is a growing interest to join to this kind of educational activities, which is easy and doable from your home. So on behalf of Sri Lanka College of Endocrinologists, I would like to welcome all of you to this educational session conducted by SLDF, Sri Lanka Diabetes Federation. And I think I will hope that you will stay with the event throughout, and I am sure that you will gain a lot of knowledge or the practical points, especially with regard to the COVID pandemic that is happening nowadays. So once again, let me welcome you all to this seminar or the workshop on diabetes care by the Sri Lanka College of Endocrinologists and SLDF, and I hope you will have a wonderful day. Thank you.
Thank you, sir. Now we can move on to the first session for the day. So let me invite Dr. Manilka Sumanatsilaka, consultant endocrinologist and of the National Hospital of Sri Lanka and chairman of the Sri Lanka Diabetes Federation. He will be discussing about new insight to diabetes care in COVID and post-COVID era.
Good morning, everybody. Once again, a warm welcome to all of you who have joined today. So we have an interesting array of lectures lined up for you today. And I'm going to start off with the current topic, diabetes and COVID, which is very relevant these days. So my lecture would be New Insights to Diabetes Care in COVID and Post-COVID Era. Can I have the slides? Yes. As you know, diabetes was the modern pandemic before the COVID pandemic surfaced in this world, and it was spreading in sort of a pandemic proportion, as you can see in the charts. You can see the numbers. This says 453, but now as of this year, there are nearly over 460 million diabetics spread across the world. And if you can see the Southeast Asia data, there's a huge number. And the projections, there is a 84% increase expected in our region, the Southeast Asia. So the hotbed of diabetes is going to be our region in future. Now you can see the COVID dashboard, the WHO COVID dashboard, so which has come up suddenly, and millions of patients, 281 million patients so far recorded, with over 5 million deaths. And diabetes claimed about 4 million deaths last year. So here we are seeing a clashing of two pandemics. So that's the focus of this lecture. How do we navigate through this, manage these two pandemics in a reasonable manner to give the benefit to our patients. So the connection between diabetes and the COVID viral infection, you can see the SARS-CoV-2 virus. It's an mRNA virus with the S proteins, or what we call as the spike proteins, which enters the cells mainly through the ACE2 receptor. And as you all know, in diabetics, these ACE2 receptors are upregulated. So the we believe that the viruses enter the cells more efficiently in diabetics. All of you are familiar with how the COVID-19 virus cause problems in people. I'm not going to talk much about that, but in diabetics the presentation may be different. In some, without any respiratory symptoms, they might have only thromboembolic phenomenon. So that's the important. Silent myocardial infarctions, strokes. A diabetic may present even without fever with a new MI or a stroke. So that you have to remember. Why do people with diabetes fare worse? So now, this pandemic, we have seen that there is a connection, plus the diabetics, especially those who have poor glycemic control, will do badly, or they are in terms of complications and death rates. The earliest report, which came from China about 1.5 years ago, showed that diabetics had a 7.3% increase risk of complications and death, followed by cardiovascular disease. But in Sri Lanka, the data I have till May, when you analyze all the deaths due to COVID in Sri Lanka, 54% have been diabetics. And if you take the above 60 category, about 74% of patients with diabetes and other non-communicable diseases have been the target, the group that has succumbed to the illness. So you could see the connection and the importance of managing diabetes in this era of COVID, and of course hopefully the post-COVID era, which should come very soon for us. And even with normal infections, you know that diabetics have an increased risk. There is increased impaired innate immune response and neutrophil dysfunction due to hyperglycemia. They say that any blood sugar level above 200 for even half an hour, especially after infections, would reduce your neutrophil function and the immunity. So it's very important that you control the blood sugars well in your diabetic patients. And of course, at risk of complications due to pro-inflammatory and pro-thrombotic state, the disease is usually associated with, and the uncontrolled immune response seen in diabetics with COVID, what you call as the cytostorm storm. Diabetes and COVID-19, there is no increased risk for infection. It's the same thing if you follow the health guidelines, and you could avoid getting infected. But if you happen to get infected, then the ICU admissions, mortality, complications, everything will be more in diabetic patients. Why is that? So this is a theory postulated where there is upregulation of this ACE receptors, and there is glycated ACE and S proteins present, and then there is enhanced viral entry into the cells, then increased tissue injury, which involves the lungs and the pancreas and heart and kidney. Hyperglycemia itself. So when the virus will impair the release of insulin from the pancreas. So that will cause hyperglycemia after the infection, which propagates this process. It becomes a vicious circle, which ultimately leads to inflammation, procoagulability, and the complications of the disease causing death. So specific measures in a diabetic that you have to do in this COVID era would be, of course, the basics. Maintain a good glycemic control. In people who are not monitoring their blood sugars, please encourage them to monitor the blood sugar levels. And then looking at their heart, maintaining the blood pressure, healthy diet, regular exercise despite all the restrictions that people have these days, and of course self-quarantine is an important factor. If there is a risk, you should quarantine yourself so that you don't spread to the others. And elderly diabetics, especially above 60, influenza and the other pneumococcal vaccination because we have seen post-COVID, people succumb to post-COVID pneumonias. They recover from COVID, but your immune system is weak and the lungs are weak, and they succumb to other bacterial and other pneumonias, viral pneumonias, after some time as a post-COVID complication. So this also is important in frail elderly diabetics. You should think about influenza and pneumococcal vaccination for your patients. During the COVID, or if there is a risk, or even in early infection, you should not change any of your routine diabetic medication. Or for that matter, there was a concern initially about ACE inhibitors. Because of this connection of the receptor, you don't have to stop your ACE inhibitors, enalapril, perindopril, ramipril, or any of those drugs. You could continue aspirin, statins, everything, which are routinely given to diabetics. And of course, you titrate the doses to ensure good control. And no benefit or harm has been demonstrated with any of the medications so far. Although there are few indications that some drugs may be useful, it's not confirmed yet. So what happens if a diabetic gets the COVID infection? You should know how to manage. The fever could be less common, and the respiratory symptoms. We have seen like the first 4 or 5 days, the patients are doing very well, no symptoms, and there is a rapid deterioration with desaturation, and so we have to look out for that, especially when you are managing your patients at home. So you need to monitor, and if possible, monitor their oxygen saturation. And some, especially the type 1 diabetics, may present with diabetic ketoacidosis or very high blood sugars, and that may be the presenting feature which represents that poorly controlled diabetes. A rather busy slide, but just to show the changes caused by the virus, which increases all these. I'm not going to go through all the factors, but interleukin 6 is a key factor. Then the angiotensin 2, fibrinogen, D-dimer, all these things will increase with the COVID infection, which all leads to increased viscosity of blood, vascular endothelial damage, hyperglycemia, which ultimately in multiple ways culminates in a thromboembolic phenomena causing cardiovascular problems in diabetics. So they may succumb to the illness due to these cardiovascular complications, in addition to the respiratory complications or the pneumonia that we see. Inpatient in a mild diabetic could be as a normal patient, even they could be managed at home, but you have to look out for, monitor the blood sugars frequently, blood pressure, then adequate amount of fluid intake is very essential, especially in diabetics, so at least 1.5 to 2 liters for a day. And of course, any specific therapy, anti-allergics, as and when symptoms require, you could give them any symptomatic treatment, and if a bacterial infection is suspected, act accordingly with the recommended antibiotics. So, glucose control targets. So, I would say it's safe to maintain, if you can, around a target of around 140 average random sugars in a diabetic, but even up to 180 is permissible in an elderly person or a person with lots of comorbidities, by avoiding hypoglycemia at all times. And if they are less, you can be less stringent if they are vulnerable for hypoglycemia, terminally ill, or unable to closely monitor the blood glucose levels. So I'm not going to talk about lots of medicines and the usual stuff in managing diabetes. I'm just talking about the concepts of the COVID and the diabetes and the management. So any of the anti-diabetic medications, starting from metformin to the SGLT2 inhibitors, empagliflozin, insulin, GLP-1 receptor agonists, and DPP-4 inhibitors, all these drugs can be used in mild to moderate COVID infection, but if there are contraindications develop, like renal impairment in a patient, then you have to stop, as you know, the usual way, to stop certain drugs, metformin. If the patient is hydration status is not good, better not give the SGLT2 inhibitor, because you all know the side effects. So other than that, there is no contraindication in mild to moderate diabetes, but COVID. But in severe COVID, of course, the drug of choice would be insulin, and especially in the patients in the intensive care units, even insulin infusion, because they'll be given lots of steroids and high-dose steroids, which will cause a hyperglycemia, which is detrimental. So we give either a basal bolus regime or an insulin infusion initially in the ICU or HDU setting. Why is the strict control of diabetes essential in these patients? This study, which came out early, I think last year, June last year, clearly shows in a cohort of thousands of patients, they looked at the death rates among diabetics with their glycemic control. So the people who had, good glycemic control, 120, 140, less than basically 10 millimoles, which amounts to about 180 milligrams per deciliter. So the death rate was just about 1.75%, whereas if the sugar goes above 180, the death rate increases by 11%. So you could see the scale of things with a slight increase in your glycemic control. So if you are infected with COVID, it's very important that you tightly control the blood sugar levels to around 140 to 150. This is a busy slide, but just to show that the virus, as I explained before, can enter your endothelium, the myocardium direct, and cause different cardiovascular problems, myocarditis, arrhythmias, plaque instability and thrombosis, myocardial infarctions and strokes. So this is the complex pathogenesis with COVID-19, which we are understanding day by day. And diabetics, as you know, on their own, they are vasculopaths. They have an increased tendency for all these complications, including plaque instability and thrombosis. So this will be augmented. This risk will be augmented by the COVID virus. So you need to continue their aspirin if they are on aspirin. But at the moment, there is no indication for any other increasing the antiplatelet therapy, say like adding a dual antiplatelets and all that. There is no evidence at the moment that you should add. But if they are on, you should continue all that treatment. Another interesting factor when it comes to young patients, we have seen whether they have diabetes or not. As you know, obesity is a risk factor for type 2 diabetes, and most of our type 2 diabetics are obese as well, and they see the ICU care and the death rate among the young population. We have seen that there's a clear indication between their BMI and their mortality and the complications. So as you can see in this paper in the Lancet last year again, BMI is above 30 has been the high risk group, highest risk being in people above 40 of BMI. Why is that? As you know, obesity itself is a inflammatory disorder. It's not just a simple, we consider it as a metabolic disorder. And in the obese also, all these changes are there. Upregulation of ACE2 receptors, there is chronic inflammation in the fatty tissue and other tissues, and there is immune system dysfunction, there is insulin and leptin resistance. All these things lead to impaired immunity, acute inflammatory reaction may be high, and obese will get a severe disease and a poor clinical outcome with COVID-19 infection. So what's the importance? So you should watch your weight as well during this critical period of COVID and post-COVID era. Coming to the post-COVID entity, now increasingly when things are settling a bit, we are noticing thousands of patients have been infected with the virus, and now we see them 2 to 3 months later post-infection, what we call as the post-COVID syndrome or the long COVID is being increasingly recognized, and there are lots of papers coming out. And diabetes also is a prominent feature in this post-COVID part of the syndrome. So they say we are increasingly seeing newly diagnosed diabetes. Of course, diabetics who got infected, they are having poor glycemic control post-COVID, and what you call as the post-COVID syndrome or the post-viral syndrome, where you get myalgia, depression, multiple aches and pains, and lack of energy, that sort of symptoms. Diabetics are at a higher risk of getting those symptoms as well. But new onset diabetes in relatively young people is also being increasingly recognized. I can't give an exact number, but there are initial data from India saying about 14 to 18% prevalence of new onset diabetes in relatively young people post-COVID. Some of them may have been pre-diabetics who have been pushed by the infection to become diabetics, and others may be having risk factors like obesity, family history, and so on and so forth. So look out for this post-COVID diabetes, and I think ideally you should screen people, high-risk people, after 3 months, 6 months, and after an year if they have got the COVID infection. This is also a busy slide where it shows the interaction between the diabetes, hyperglycemia, and the complications that you see in different organs in patients with COVID infections. But I'm not going to go through all that, which has been explained, and this summarizes that. And there's another interesting, this came out in the BMJ recently, where they have analyzed about 86,000 patients with the in-hospital COVID during the study period, out of which they have chosen about 47,780 patients were analyzed after choosing which suited the study criteria. And this is what they have found, that the per 1,000 patients, incidence of diabetes, MACE, and major cardiovascular events, chronic kidney and liver diseases, you can see the numbers there, and new onset rates are also seen. So diabetes comes second there during the study, in that study of 47,000 patients. So they had other major cardiovascular incidents were seen. Then new onset diabetes was the second most common metabolic complication that they saw in patients with COVID infections who were admitted to hospital. So it's an important area in this era of COVID and post-COVID to look out and screen for diabetes, manage the diabetes well, and of course screen for complications of diabetes as well. So how do we few minutes to say to talk about the new normal and how do we adapt, or the new insights into managing diabetes. So it's not just giving medications, the lockdowns and the problems associated with that, sedentary lifestyle, changing of their lifestyle, some people may have a depression, change in their income levels. All these things matter when it comes to diabetes. So you need to have a holistic approach when you are managing the diabetes these days, looking at all the social and economic and other factors, taking all these things into account when you are managing your diabetes patient. The challenges, as you know, have been the sedentary lifestyle, depression, lack of access. This year's theme for the World Diabetes Day is access to diabetes care, which is very relevant. The access to diabetes care was greatly hampered initially, and then we managed to overcome that through many methods, telemedicine, posting the medication, and you must encourage your patients to overcome these things and think in a different way and do innovative things to overcome the difficulties that they face during this period. What can you do? Home gardening, getting together with the family and exercising at home. You don't have to go to a gym to exercise. So think and do something, upper body exercises. You can be doing that even being seated. You don't have to go out or to a walking path or a track. Telemedicine, then things like meditation or relaxation things, socializing using the technology without minimizing the meeting or the contacts with others, which is very important. Otherwise, people go into depression. So, basically, this has been summarized in this, and of course, drink plenty of water. That comes first because of this all this thromboembolic phenomenon that we see with COVID and diabetes. So, encourage your patients to drink at least 1.5 to 2 liters of water, among other things. And this cartoon explains the other measures which I have explained before. Telemedicine and or telehealth came to the fore and to the rescue in some instances where we could deliver our services to our patients using the technologies that we have. And even in our government clinics, we had a hotline number where patients could connect with us, and we could could send their reports, and we change their medication, and then we have posted the medication using this method. So think in a new way, where instances where you could use these technologies without getting down your patients to see you and to manage your diabetes. So summarizing all this, in the COVID and the post-COVID era, I would say prevention is the best. It applies to all. So the preventive measures should be done. Diabetics to take extra care not to get infected with the virus. And of course, I have summarized on the left-hand side the measures that we do for a diabetics if they get COVID and during this era and the post-COVID era. Think about, there is an implication about the medication given in COVID. There are lots of steroids given. So new onset diabetes may be affected by the steroids, or the poor glycemic control also will be affected by the steroids. But we need to take all these factors into consideration and take a holistic approach when you are managing diabetes in this era of COVID and post-COVID era. I suppose if you are vigilant and constantly monitor the sugars, adjust the medication and strive to achieve a good glycemic control, our diabetic patients will pull through this epidemic and will have a healthy and a happy life. Thank you very much.
The next lecture for the day is Diagnosis and Monitoring of a Diabetic Patient. It's my pleasure to introduce you to the speaker, Dr. Mudita Veerakodi, Consultant Endocrinologist at Teaching Hospital Galle, who will be joining with us virtually today. Over to you, madam.
I'm not sure how to do it. Okay, can you hear me? Hello? Can you hear me? Hello?
Yes, madam. We can hear you.
Can you hear me?
Yes,
Hello?
yes, we can hear you.
Yeah, I just trying to share the slides. I don't know what's happening. Just give me a minute, okay? Screen share. Can you see them now? The slides.
Not yet, madam.
I have sent the slides to you. Maybe you could put it. Yeah. How do I do that? Can you see this now? Hello?
Yes,
Yes,
madam.
can see.
You can say.
Yeah, right. Okay. Shall I start then?
Okay.
Yeah, right. Okay. Sorry about the delay. So I'm going to talk to you about diagnosis and monitoring of a diabetic patient, right? So I think we we have a lot of things that we know, but we want to recap what we are talking about. So first of all, I would like to talk to you about classification of diabetes. So as we all know, we've got four types of diabetes. Type 1 diabetes, which is due to autoimmune beta cell destruction, usually leading to absolute insulin deficiency, including latent autoimmune diabetes of adulthood. The second type, where most of our people would fall into, would be type 2 diabetes, which is due to a progressive loss of beta cell insulin secretion, frequently on the background of insulin resistance. So, therefore, although we would have high insulin levels at the beginning of type 2 diabetes, after about 10 to 15 years, there would be almost a total destruction of beta cells of the pancreas, and they would need insulin. And we also got other specific types of diabetes due to other causes. For example, we've got monogenic diabetes syndrome, such as neonatal diabetes and maturity onset diabetes of the young, and diseases of the exocrine pancreas, such as cystic fibrosis and pancreatitis. Although cystic fibrosis is not common in this part of the world, we do have a lot of chronic pancreatitis and also drug or chemical induced diabetes, such as steroids. And we also have the fourth type, which is the gestational diabetes, which is diabetes diagnosed in the second or third trimester of a pregnancy. Right. So, first of all, before we go to the diagnostic criteria as such, let's look at how we can differentiate between these different types of diabetes. I have put how to differentiate between type 1 and type 2 here, because as we know, type 2 is the commonest type of diabetes in our parts of the world, as a matter of fact in the whole world, and type 2 is less common. Type 1 is less common. So so we used to think that type 1 occurs in young people and type 2 in older individuals, which is not the case now. We see more and more younger people getting type 1 diabetes. So it could be a bit confusing to the medical officers sometimes to differentiate between type 1 and type 2. So type 1 usually still occurs at a younger age, whereas type 2 can occur at any age. So I have seen that children as young as 9 years of age who come with type 2 diabetes. So more importantly, one way of differentiating between type 1 and type 2 is whether it's acute onset or subacute onset. Because type 1 is having absolute insulin deficiency, the onset is very rapid. The patient would have osmotic symptoms for maybe 1 to 2 weeks, or or present with a complicated infection. Whereas in type 2, patients would be asymptomatic for a long time, and most of the time would be detected incidentally. And of course, type 1 would have a lot of symptoms, whereas type 2s would be asymptomatic. And type 1s are lean body mass, whereas the type 2 is obese. Um, right. So also there are other ways of differentiating, like sorry, I've been asked to put the slideshow, but I have put the slideshow actually on this. Yeah. So type uh, type 1 would have autoimmune markers like islet cell antibodies and GAD antibodies, whereas type 2 wouldn't have them. But of course, having said that, it's quite expensive to do autoimmune markers on each and every individual whom we suspect type 1. Type 2, of course, would have other comorbid conditions like high blood pressure and dyslipidemia, which are all part of the metabolic dysregulation. And type 1s would need insulin, whereas type 2s, most of them could initially be managed with oral hypoglycemic agents. Now, as I said before, type 1 2 is mostly asymptomatic, so we need to kind of detect them before they develop complications, because as we know, even at the time of diagnosis, a certain percentage of type 2s have already developed diabetic complications. So how do we screen for diabetes is the question. So these are the American Diabetes Association criteria for screening of type 2 diabetes. So what they say is you should consider it for all adults who are overweight or, excuse me for a minute. Hello, hello. Moving. I cannot put in the slideshow. Let me stop sharing and then see what's wrong. Okay. Hello? Hello? Hello?
Yes, yes.
Yeah, can you hear me?
Yes, madam. Yes.
Okay, sorry about it. So I think this was, can you go to this was what I discussed between four types of diabetes. And can you move to the next slide, please? Yeah, right. So this is again what we discussed about differentiating between different types of diabetes, type 1 and type 2. And next slide, please. Next slide, please. Okay, right. So again, this is what the previous slide. Previous slide, please. Yeah. So this is what the American Diabetes Association suggests for screening for type 2 diabetes, because as we said, most of the type 2 diabetic patients are asymptomatic. So they suggest that you start testing anybody who is overweight or obese with other risk factors for diabetes. And also, if you do not have any risk factors for diabetes, at the age of 45, you need to start screening your patients for diabetes. And if the results are normal, you need to keep repeating them at least every 3 years. Next slide, please. Right. Okay. But these are what we have put out from our Ministry of Health and our NCD units, because for our local population. Now, as you can see, these are the guidelines for screening for non-communicable diseases as a whole, and as opposed to American recommendations where they recommend to start screening at 45 years of age. We are going to start screening earlier at 40, and even earlier if you've got any other risk factors like smoking, overweight, obesity, raised blood pressure, history of premature cardiovascular disease, and so on. This is because, as we know, as Manilka said, in South Asia, we are facing a diabetic epidemic. So, Western population. Next slide, please. Next slide, please. Right. Okay. So the diagnosis criteria, how do we diagnose diabetes? It is simple, bread and butter. Just to recapitulate. So in asymptomatic individuals, a fasting plasma glucose of more than 126, where the fasting is defined as no caloric intake for at least 8 hours, or a 2-hour postprandial blood glucose of more than 200 during an oral glucose tolerance test, or an HbA1c of more than or equal to 6.5. Now, the important thing that you need to note is that in asymptomatic individuals, you need to repeat the same test again before coming to the conclusion of diabetes. However, in symptomatic individuals, you could just go on with one test. And in patients with classic symptoms of hyperglycemia, you do not need a fasting plasma glucose or OGTT or HbA1c. A random glucose of more than 200 is also adequate for the diagnosis of diabetes. Next slide, please. Right. Okay. So when we're talking about HbA1c or glycosylated hemoglobin level, we need to keep a few things in our mind. One thing is it should be done in a standardized laboratory. And we know that there are many laboratories and many methods of doing glycosylated hemoglobin levels, and some of them are not so good as others and are prone to errors. And also there are certain physiological and pathological conditions in patients that would give erroneous results in HbA1c. So things like hemoglobinopathies or pregnancy, especially in the second and third trimesters, and also postpartum. Illnesses like glucose 6-phosphatase dehydrogenase deficiency, HIV, hemodialysis, recent blood loss or blood transfusion, erythropoietin therapy. These can have a will be affecting the HbA1c in a different level. So therefore, you cannot use HbA1c either for the diagnosis or for the management of diabetes in these type of individuals. Next slide, please. Right, okay. So I just want to highlight how to diagnose pre-diabetes or how to define pre-diabetes. Now, as we all know, most of the studies have shown that there's a continuous relationship between the blood glucose level and diabetic complications, whether they are microvascular or macrovascular. So you cannot have just one cutoff and say, okay, after fasting plasma glucose of 126 or HbA1c of 6.5, you get complications, and below that you do not. Because there have been many evidence to say that individuals who have that in-between range of blood glucose, they're not diabetic, nor they are normal, that they're still having, they are at risk of developing overt diabetes, and they are at risk of developing complications of diabetes. We have defined this entity called pre-diabetes, where the fasting plasma glucose is between 100 to 125, or if the 2-hour postprandial value is between 140 to 199, or the HbA1c is between 5.7 to 6.4. So these people are, they categorized as pre-diabetes, and depending on the amount of blood sugar that is raised, the risk of developing diabetes in the future or complications of the future is high. And depending on other circumstances, we can decide to treat them or not. And also, of course, all of them would need diet and lifestyle modification, just like in an overtly diabetic individual. Next slide, please. Next slide, please. Right, okay. So I'm going to talk about, since my topic is diagnosis and management of diabetes, I'm going to also talk about how to diagnose pre-gestational or gestational diabetes. Now, what we classically define as gestational, now these are the criteria that we have put out by the Sri Lanka Diabetes Federation and the College of Obstetricians. So there are various cutoffs and various guidelines in various colleges around the world, but this is what we have individualized for our Sri Lankan population. So anything that is diagnosed in the 2nd or 3rd trimester would go as gestational, whereas anything that is diagnosed before that, usually in the booking visit, goes as pre-gestational diabetes. So pre-gestational diabetes diagnosis is straightforward, just like for non-pregnant individuals. But if you've got your blood glucose in the pre-diabetic range, you need to proceed to a 2-hour 75-gram oral glucose tolerance test. And again, at 24 to 28 weeks too, if your previous tests were normal, you could still go on for an oral glucose tolerance test. And the cutoffs are slightly different to different colleges and different other associations. So what I have put here is what you call gestational diabetes. As you can see, it's a 1-hour value of 180 or a 2-hour of 140. Next slide, please. Right. So then we have to have a individualized as well as a holistic approach to the management of and the monitoring of diabetes. So this is what we call ABCDE triple S. So we of course need to keep the HbA1c targets. We need to keep our blood pressure targets. We need to keep our cholesterol targets, and also now what we newly discussed is to reduce the cardiac risk when appropriate by using whatever methods. And we also have exercise targets, and very importantly, supporting and self-management, smoking cessation, and of course, screening for complications, which will be discussed by my colleagues later on today. Next slide, please. Right. So should we try to achieve tighter HbA1c goals is the next question. Next slide, please. Right. So various studies have shown over the years that reduction of blood glucose is associated with reduction of both microvascular as well as macrovascular complications. So this is from the UKPDS and the UKPDS follow-up study. So what they show was for each 1% reduction or each 1% decrease in glycosylated hemoglobin levels, there is a 43% reduction in amputation or peripheral vascular disease death, 37% reduction in the risk of microvascular complications, 21% reduction in the risk of diabetes-related deaths, 14% reduction in the risk of myocardial infarction, and 14% reduction in all-cause mortality. But having said that, later on, studies like ACCORD showed that in high-risk individuals, glycemic control or reducing HbA1c level to very low values is detrimental. So we need to have an individualized target for each and every patient. Next slide, please. Right, so individualization is the goal. Next slide. Yeah, and as you can see, just like a shoe, one size does not fit everybody. Next slide, please. Right. So when we are considering about our glycemic targets, we need to see whether we are going to have a very tight glycemic control or whether we are going to kind of loosen it a bit. So it will all depend on so many other factors, not just the blood glucose level, whether the patient is having adverse effects with hypoglycemia, the duration of the disease, the life expectancy of the patient, whether the patient is having other comorbidities, especially established cardiovascular disease, and what's the patient's attitude and expected treatment efforts. So if it's a newly diagnosed diabetic with good financial support, social support, long life expectancy, no comorbidities, we could go for a very tight glycemic control, maybe to an HbA1c of 6 to 6.5. Whereas if it's a person at the other spectrum, we need to have a kind of a lax glycemic control to avoid further complications. Next slide, please. Right, so these are the American Diabetes Association recommendations for all the individuals and their glycemic goals. What they say is that even in an older individual, if the patient is healthy, you could go for try to achieve a target of HbA1c of less than 7.5 with a fasting or pre-prandial glucose of 90 to 130. Whereas if it's a patient with some complexity or intermediate poor health, we could go for an HbA1c of about 8%, less than 8, and in very frail individuals of about 8.5. So we need to individualize our treatment targets. Next slide, please. Right. So, but generally what we recommend is to keep a pre-meal blood glucose of about 80 to 130 and a postprandial blood glucose of about 180 less than 180 milligrams per deciliter and an HbA1c of less than 7. So this is the general recommendation, but as I said before, we need to individualize our treatment goals. Next slide, please. Next slide, please. Yeah, right. And also when we are talking about our glycemic goals and targets and monitoring, we also need to think about whether the patient is becoming hypoglycemic. Yeah, hypoglycemic. So these are the various classifications of hypoglycemia, and what we need to know is that at level 3, which is severe hypoglycemia, the patient cannot manage the hypoglycemia alone by himself or herself, which would be a disaster. Next slide, please. Next slide, please. Okay. And also there is this concept. Now, sometimes you might come across patients who come to you with a HbA1c report and ask you what their blood glucose level is in the normal standard units in milligrams of deciliter or something. So there is, with the use of HbA1c, you can do an estimated average blood glucose for that individual to easily explain where they stand. So this either you can take a photo or keep it, or there are apps on the phone where you can use it readily then and there to explain to the patient what their glycosylated hemoglobin level means. So therefore you can give them an estimated average glucose for that individual. Next slide, please. Next slide, please. Right, okay. So follow-up and monitoring. So finally, follow-up and monitoring involves, as we said, now I've only talked about management of the glycemia, but it would also involve looking at so many other things, like looking at their cardiovascular risk factors, whether they are having any established cardiovascular disease, what their 10-year cardiovascular risk is, and whether they're having chronic kidney disease at the moment or risk of kidney disease, and what their risk of hypoglycemia is, and of course discussing with the patient and setting some glycemia goals, the glycemic goals, and monitoring to see whether those goals are achieved from time to time. And of course, this would also involve things like lifestyle management, pharmacological therapy, to reduce blood glucose, as well as pharmacological therapy to reduce their cardiovascular risk. So what we mean by monitoring of a diabetic patient is not only monitoring their blood glucose levels, but monitoring for complications, monitoring for their persistence with lifestyle modification, monitoring their persistence with exercise, daily to exercise and activity levels and all that. So I think my colleagues will be talking to you about all these other aspects in the next presentation. So I think we are going to stop now, and I'm sorry I took some extra time because of technical problems. Thank you.
Thank you, Madam. Next, I would like to invite Dr. Sivadarsha Padmanathan, a consultant endocrinologist at the National Hospital of Sri Lanka. She will also discuss about a very important topic, that is latest approach to achieve the individualized glycemic target.
Good morning, everyone who has joined virtually for our annual diabetes program. And I thank the organizers for inviting me to do this lecture. In the next 20 minutes, I'm going to take you through to the latest approach to achieve the individualized glycemic target. So, I will be covering the increased prevalence of diabetes, a short on natural history and the pathophysiology, and I will talk a bit about the new drugs, the incretin effect and how the SGLT2 inhibitors work. And we already know the first option, the metformin, and how we can choose the second one. And a comparison of DPP4 inhibitors and the SGLT2 inhibitors. And I will briefly explain to you the latest data on empagliflozin. And although we have been using metformin as the first line drug, what are the issues we face with metformin? So you know the prevalence of diabetes is ever increasing, and currently there is about 463 million people living with adults, and every 1 in 11 have diabetes, of which actually unfortunately 50% don't know that they are having diabetes. And 75% of these patients live in low and middle income countries. So therefore, although this year theme is access to diabetes care, there is problem for these patients having a good access for their diabetes control. And 1 in 3 adults have of these 1 in 3 adults have diabetes glycemic intolerance. So, you know, the number of diabetic patients are ever increasing, and it has tripled over the past 20 years, and it has been estimated by 2045 there will be at least 700 million will be living with diabetes, of which 82% comes from the Southeast Asia, from where we come from. And actually, you know, IDF have estimated at least 1.2 billion people died due to diabetes related complications in 2019. So in fact, one death every 8 seconds occur due to diabetes or diabetes related complications. We know obesity and sedentary lifestyle are the trigger for diabetes, and when you take the complications, diabetes is the leading cause for blindness, end-stage renal failure, and 50% of all non-traumatic amputations occur due to diabetes. And there is, when you are a diabetic, there is a 2.5-fold increase of stroke and 2 to 4% increase in the cardiovascular mortality. Right. So, this actually tells you you have to have a good glycemic control. So, actually the complication starts with the duration of diabetes, and initial the practice that we had was when you are diagnosed with diabetes, you tend to start with diet and exercise, and gradually the number of drugs are titrated. But now we have a slightly different approach. We try to tackle, if the HbA1c is more than 10, from the onset itself we try to introduce multiple drugs and try to reduce the HbA1c so that we can prevent these complications. So, earlier the better. So, early detection, what we are trying now is to detect these patients in the pre-diabetes stage as well. So, the thing is, like, according to the studies that studies have shown, the risk of macrovascular complication, especially the cardiovascular disease, starts when you are in the pre-diabetic itself, and the microvascular complication starts with the onset of diagnosis of overt diabetes. So, if we have an improved care, diagnose these patients at an early stage, in the pre-diabetes stage, we can prevent the macro as well as microvascular complication. So, let us have a look of the pathophysiology of the natural history of diabetes, because it helps us to get an idea of how some of these drugs work. So, diabetes is a progressive disease. Before the onset of the clinical diagnosis, you have a pre-diabetes stage where the insulin secretion or the function diminishes. So, in the pre-diabetes stage, initially it is the postprandial blood sugar that gets impaired, and then the fasting blood sugar. So, if you are doing or monitoring the patient only with the fasting blood sugar, probably you might not catch these patients early. So, that is why Mudita had elaborately explained to you how these patients should be diagnosed in the pre-diabetes stage itself. This is what I have already told you. The macrovascular complication starts in the pre-diabetes stage, and the microvascular complication starts with the onset of diabetes. So, this the type 2 diabetes has a multifactorial pathogenesis. So, it is the hyperglycemia which acts on the number of organs and collectively that results in diabetes. So, in kidneys usually there is increased glucose reabsorption, and then with the diabetes there is a decreased incretin effect. So, the postprandial sugars become high. There is increased glucose production from the liver, and similarly the insulin secretion diminishes in the pancreas, which is the first thing. Even in type 2 diabetes, together with the insulin resistance, the insulin secretion diminishes over time when the patient becomes over diabetes. And in the muscles also there will be reduction of the glucose uptake. And in type 2 diabetes, it has been proved there is neurotransmitter dysfunction as well. So, all in all, the combination of these things result in hyperglycemia. And when you look at the drugs which has been diagnosed or probably used for the control of diabetes, insulin was the first one, and we are now celebrating 100 years of insulin, and then came the sulfonylureas, And the biguanides, although they were diagnosed a little early, probably came into practice a little later. We have other armamentarium of the other drugs as well, like the alpha glucosidase inhibitors, thiazolidines, GLP-1 analogs and all, but the newer ones, the DPP-4 inhibitors and the SGLT2 inhibitors are the newer drugs, probably somewhat newer drugs, not so new anyway, which is, playing a really big role in the control of diabetes. So this slide depicts the reduction in the HbA1c with each anti-diabetic treatment. Of course, you can see insulin is the most important one. None of the drugs can come even closer to it, so it causes about 2% reduction in the HbA1c. So when you manage the diabetes, it is the lifestyle modification, and previously we have been trying lifestyle modification and waited for some time before we introduced the drugs, but now we are parallelly doing things because we want to control the HbA1c as much as possible. So with the lifestyle modification, metformin is the #1 drug. So, but the dilemma is what is the drug that we are going to use as #2. So again, we have a few options like the DPP-4 inhibitors, SGLT2 inhibitors. You can use basal insulin if the sugar controls are really a problem. GLP-1 receptor agonist, of course, it has problem with the availability and the cost is an issue. Sulfonylurea is a good choice. It's cost, but probably not a good drug when you consider the long-standing effect on heart and kidneys. And again, glitazones. So when you see a patient, previously we have been practicing like one rule fits all, but now we are selecting the drugs according to an individualized patient basis. So there are a set of patients who will be sitting in front of you, where you have to decide on which drug I am going to start. So these are some of the different classification of patients you will be seeing in your practice. Patient can be having type 2 diabetes with obesity. Patients has at risk of renal impairment. So you have to choose drugs which will, not affect their renal functions further. Elderly patients, patients with lot of comorbidities, and patients with primary cardiovascular disease, patients who have risk of hypoglycemia and renal function. So the individualized treatment depends on what type of patient is sitting in front of you. And there are patients like post-stroke patients who are like having poor support, so has the risk of dehydration, so probably SGLT2 inhibitors are not a good choice in them. And some patients may not come for follow-up. So the problem is if there is already a mild renal impairment, and if you start a drug, for instance, whether it could be metformin or SGLT2 inhibitors, if the patient do not come for follow-up visit, there is a risk that they might continue your prescription and might run into trouble. So you have to decide on, which drug I am going to choose, and probably you have to carefully assess your patient and select what you are going to start in this patient. So let's see what do the guidelines say. So this probably is not clear to you. So let me show it one by one. So let's take a patient who has diabetes but has established cardiovascular disease or kidney disease. So what does the guideline say? So in these patients, after the metformin, you can either choose a GLP-1 receptor agonist or SGLT2 inhibitors. I'll briefly explain to you why these drugs should be selected, and in case if those two cannot be, because they have the proven cardiovascular safety and the renal safety, and if those two cannot be selected, probably you have to select something which doesn't have any detrimental effect on the cardiovascular status. For instance, DPP-4 inhibitors, basal insulins or sulfonylureas are going to be the other choice. In patients who has cardiovascular disease, but again if they have heart failure or CKD predominates, probably SGLT2 inhibitors are preferred next to the metformin, and if the SGLT2 inhibitors are not tolerated, contraindicated, or EGFR is less than 30 or probably 25, then probably you can add a GLP-1 receptor agonist, or probably add any of the drugs which has been mentioned here, like again the DPP-4 inhibitors, basal insulins and sulfonylureas. But in patients who doesn't have any established cardiac disease or kidney disease, but has the risk of hypoglycemia. So in these patients, you have to select a drug which causes minimal hypoglycemia. So probably you know sulfonylureas and insulins are not the best options. So here you can either select a patient with DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, or thiazolidinones. These drugs, they do not cause hypoglycemia, so you probably can introduce one of these drugs if the patient doesn't have established cardiovascular disease or kidney disease. If they have established cardiovascular or kidney disease, probably as I mentioned earlier, GLP-1 receptor agonist and SGLT2 inhibitors gain the superiority. So if one of the drug is started and still the glycemic targets are not met, probably you can interchange or probably add on another drug which in the same thing. Right. And in patients who are obese without diabetes and obesity, so then again you must select a drug which doesn't cause weight gain or probably promotes weight loss. So in that case, after metformin, probably SGLT2 inhibitors and GLP-1 receptor agonists again takes the superior place because they promote weight loss. And if they are not tolerated, contraindicated, or if still the glycemic targets are not met, probably the other drugs like DPP-4 inhibitors which are weight neutral can be considered. Sulfonylurea and glitazones are probably, they cause, glitazones are weight neutral, but then sulfonylurea causes weight gain. So probably that is not a good option in patients who you want to lose some weight with your treatment. And in patients especially, this is a major problem in our part of the country where the cost is a major issue. SGLT2 inhibitors and GLP-1 receptors are costly and not probably affordable with all patients. So in those patients, probably your next choice after metformin is either going to be sulfonylurea or thiazolidinones because they are less costly. So your individual choice depends on the patient sitting in front of you, whether the patient has diabetes alone or with diabetes with established cardiovascular disease or kidney disease, or probably like patients whom you want to have some weight loss, or in patients who has a risk of hypoglycemia, elderly patients, risk of dehydration, or in patients cost is a major issue. So this is what the ACC guideline says. When you start with the metformin, and with the patient is having an established cardiovascular disease, you have to probably give priority for GLP-1 receptor agonist and SGLT2 inhibitors, and then if they don't have established cardiovascular disease, you have other options and you have to select it according to the patient sitting in front of you. I'm going to talk, because this choice of these drugs depends on on the pathophysiology of the drugs, how they work. So I'm going to talk about the incretin effect. Incretin is a gut hormone secreted in response to the oral glucose load. So there are two drugs which act according to the incretin effect, the DPP-4 inhibitors as well as the SGLT2 inhibitors. This incretin effect mainly tackles the postprandial hyperglycemia. So, in patients in whom the postprandial sugar targets are not met, probably DPP-4 inhibitors and SGLT2 inhibitors are the better choice. In type 2 diabetes, what happens is, in this incretin effect is diminished. So, therefore, these drugs, the DPP-4 inhibitors and the GLP-1 receptor agonists are a better choice, because what they do is they increase the incretin effect. The blunting of the incretin effect is alleviated. So, these two drugs mainly help to tackle the postprandial hypoglycemia. So, you know, the DPP-4 inhibitors, usually the natural GLP-1 is rapidly deactivated by the enzyme DPP-4. So, these DPP-4 inhibitors, they inhibit the deactivation of the GLP-1 analogs, GLP-1 levels, and therefore, it restores the incretin effect. So, DPP-4 inhibitors and GLP-1 receptors are two options that we have where it mainly tackles the postprandial hyperglycemia. You will be knowing more about them in the following the lectures that are going to follow, mainly concentrating on the different classes of drugs as well. So, in patients, I told you the different problems we encounter. Very rarely we see patients who has only diabetes alone. So, in patients with kidney disease, we have to select a drug which doesn't further deteriorates the kidney. So, SGLT2 inhibitors are drugs which acts on the kidneys. Usually, you know, 90% of the reabsorption occurs in the proximal convoluted tubule through the SGLT2 receptors. So, this SGLT2 receptor is an active glucose transporter which transports with sodium. So, the thing is, SGLT2 inhibitors, they inhibits the SGLT2 receptors, so then the glucose reabsorption is inhibited. So, what happens is, you know, the patient get glycosuria and diuresis. So, this SGLT2 inhibitors, they reduce the plasma glucose, reduce their body weight. Because of this diuresis effect, there is effect on the blood pressure as well as they act on the heart as well, and they reduce the plasma uric acid, and it reduces the glomerular hyperfiltration, which is seen in the initial part of the diabetic kidney disease. So, this slide depicts the action of the SGLT2 inhibitors, which probably I am going to rush through because of the time constraints. So, in patients with established cardiovascular disease, the new guideline says to select, which I have already mentioned, to select a drug, either a GLP-1 receptor agonist or SGLT2 receptor inhibitors. But the problem is GLP-1 analogs, although we have many options, there are three major issues with these drugs, because these are injectables. So, most of the patients may not like, it is very costly, and the side effects, the GI side effects are more. So, then the other option is the SGLT2 inhibitors, and according to this famous trial, the EMPHARAGE outcome, these SGLT2 inhibitors, it has found that if you introduce a SGLT2 inhibitor in a patients with established cardiovascular disease, it causes 14% reduction in the 3-point MACE. There is a 38% reduction in the cardiovascular disease and 32% reduction in the all-cause mortality, and reduction in the hospitalization related to heart failure, and also the good thing is it reduces a new onset or worsening nephropathy. So, in patients with heart failure, 3 trials have looked into that. The EMPHARAGE trial, the EMPHARA reduced, where they mainly looked at patients with reduced ejection fraction, and the EMPHARA preserved where the patient has heart failure with preserved ejection fraction. So, because of the constraint of time, I am going to rush through this. So, all these studies, what they have showed is there is a reduction in the primary endpoint, secondary endpoint as well as, so that is there is a reduction in the cardiovascular death or heart failure, and there have been reduction in the hospitalization due to heart failure, as well as reduction in the glomerular filtration rate over time. So, all these studies have given promising results. SGLT2 inhibitors is a better choice in patients who have established cardiovascular disease, either with established heart failure with preserved ejection fraction or without preserved ejection fraction. So, this trial again mainly concentrate on patients with preserved ejection fraction. So, let us say look at a patient who has obesity and you want a drug which causes some weight loss. Again, as I told you, DPP4 inhibitors, which acts mainly on the incretin effect, are weight neutral, and the best option that we have is the GLP-1 receptor agonist and SGLT2 inhibitors. GLP-1 receptor agonist in our part of the world, as I mentioned, the three major effects, apart from the GI side effect, is the cost, and since it's an injectable, not properly preferred by all. But SGLT2 inhibitors, if you introduce, probably there is a reduction of 3 to 5 kilos. So, the good thing is patient won't gain additional weight, as well as there will be the patient will be losing about 3 to 5 kilos. So, in patients with hypoglycemia, this risk is common in patients, in elderly patients and patients who have minimal family support, who lives alone and probably have problem with their feedings, who are on NG feeds and PEG feeds and all. And in patients who don't have hypoglycemia unawareness, drugs which causes hypoglycemia is definitely not the best choice. So, in those patients, we have to select a drug which does not cause hypoglycemia. So, definitely sulfonylurea is not going to be the option, and insulin again is not probably a good choice. So, these patients, again you can see from the list, the SGLT2 inhibitors come into play and come as first in the list. But the problem in elderly who has the risk of dehydration, probably SGLT2 inhibitors are not a good choice. In chronic kidney disease, I have already probably elaborated on this. The new trials, SGLT2 has very promising results. So, in established kidney disease, as well as in when you introduce SGLT2 inhibitors, it has been noted there is improvement in GFR as well as no new onset of kidney disease. So, in patients, still SGLT2 inhibitors are recommended when the GFR is more than 30, but the new studies, they have tried even GFR 25. So, probably in GFR above 25, SGLT2 are the better options, but in patients with low GFR, you have to introduce these drugs where you can. So, in patients probably maybe lost to follow, compromised renal functions, you have to think twice before you start these drugs. So, when we look at the SGLT2 inhibitors as well as the DPP4 inhibitors, there are certain features that you have to consider when you compare them. One is the HbA1c reduction. Both have moderate potency where you can have a reduction of 0.4 to 0.8. Cardiac safety, of course, as I explained to you, SGLT2 inhibitors are the superior. The DPP4 inhibitors are weight neutral, whereas SGLT2 inhibitors causes weight reduction. Hypoglycemia risk is less in both the category. Both the drugs are probably now commonly available, but cost may be a problem. and both are taken as tablets, so no injectables. That again is an advantage, and usually the DPP-4 inhibitors are well tolerated compared to SGLT2 inhibitors, so probably DPP-4 inhibitors. But again, from the cardiac point of view, the renal point of view, certainly SGLT2 inhibitors have promising results. So in DPP-4 inhibitors, apart from the linagliptin, you have to consider dose reduction with the GFR they have, and when you compare with the SGLT2 inhibitors, currently if the GFR is less than 30, they are not recommended, but probably we can try under close supervision in patients who have a GFR of around 25. So I have probably help you to get some idea how you have to select your second drug, and from the options that you have depending on the patient who sits in front of you, who may not be having only the diabetes but having the other complications as well. So, but again, I started with the thing saying that metformin is the drug of choice. But again, metformin, again, you might have faced a few similar symptoms. So this is a similar problem. So this is a clinical scenario whom almost all would have faced. You started a new diagnosed patient with HbA1c of 7.2 and had a fasting blood sugar of 153 on metformin. But in few weeks time, he comes back to you with dyspepsia, abdominal pain and bloating. So how common is this scenario? Very common, and that is called metformin intolerance, because 25% of these patients usually suffer the GI side effects, of which about 5% they don't tolerate metformin at all. You have to, whatever the way you try, you probably have to discontinue. So of the GI side effects, the diarrhea and heartburn are the commonest, and they also complaining of abdominal bloating, retching, etc. So the thing is, like, metformin is the drug of choice unless it's not tolerated by patients or contraindicated. So the second drug depends on the patient sitting in front of you, and hopefully I have given you some insight for you to decide on which is going to be the second drug for your patient. Thank you for your patient hearing.
Lined up next is the all-important insulin therapy, past to present. So it's my great honor to introduce you to the speaker, Vidya Jyoti Professor Prasad Katulanda, consultant endocrinologist and head of the Department of Medicine, Faculty of Medicine, University of Colombo. Over to you, sir.
Good morning. So first of all, let me thank the organizers for inviting me to talk to you on insulin therapy today. Can I have the slides? We just celebrated 100 years in the discovery of insulin by Banting and Best. Can I run with this? So this is what happened to people who got, particularly kids with type 1 diabetes, before insulin therapy. They got ketoacidosis and went into coma, and the discovery of insulin completely transformed the lives of these people from almost certain deaths to survival to much later life. And this is a similar girl who was treated initially with insulin, and she lived up to about 70 years. And insulin deficiency, if it is acute and severe, can lead to many metabolic complications like diabetic ketoacidosis and hyposmolar status, and when it is chronic, would lead to chronic microvascular complications and increasing cardiovascular death. Over the last 100 years, we have come all the way where we have got crude insulin extract from the pancreases of animals, and then to semi-synthetic insulins where animal insulin was modified to the human sequence. Subsequently, genetic engineering led to the discovery of human insulin, and then further advances led to the discovery of the insulin analogs with much smarter properties, and also things are improving year by year. So to understand the insulin therapy, we need to have some understanding on insulin physiology, where in normal people, when we eat meals, we get a surge of insulin. And to control the blood glucose and to prevent lipolysis in between, we have a basal rate of secretion of insulin, as you can see here. And what happens in type 2 diabetes is you have some insulin secretion, but the first phase insulin initially and subsequently the second phase is much lower. And in type 1, there is absolute insulin deficiency once it is fully set. And the indications for insulin therapy in type 1, life-saving. In type 2 diabetes with long-standing beta cell failure, you need to give insulin for control. And in type 2, actually, there is an opportunity to give insulin to reverse glucotoxicity if we are attempting regression of diabetes. And also, when there is oral hypoglycemic agents contraindicated in certain conditions like pregnancy, and also in short periods where people are acutely unwell, like with steroid therapy you might need. And there is enough evidence for use of insulin for type 1 diabetes. These seminal data you see here are from the diabetic control and complications trial on type 1 diabetes, which has showed with intensive glycemic control with insulin, you can reduce microvascular complications. And then also data from the UKPDS, as shown here, showed insulin or intensive blood glucose reduction with sulfonylureas reduces all microvascular complications, and subsequent follow-up data from the UKPDS study showed that even macrovascular complications can be reduced. You can see in this famous UKPDS beta cell graph, with time, at the time of diagnosis, your blood glucose, the beta cell function is about 50%. And then with time, this goes on. So that is why we call type 2 diabetes a progressive disease with progressive decline of beta cells. So when there is the significant decline of beta cell function, you need insulin therapy. And in UKPDS, these data showed that about 77% of the people needed insulin ultimately for proper control of blood glucose. And some situations, as I said earlier, like in pregnancy, surgery, intercurrent illnesses, particularly with steroid therapy, we saw this a lot during the COVID pandemic. And also in patients with acute myocardial infarction, like the DIGAMI study has shown some benefit of insulin infusion. And then also, early insulin treatment has shown that there is some opportunity to preserve the beta cells. Then people might wonder why you need to preserve beta cells when you need insulin. But if you have some amount of beta cell function preserved, still there is more physiological handling of blood glucose, so you will not get dramatic fluctuations of your blood glucose. So these are the benefits and challenges of insulin therapy. You can restore beta cell function, and also produces quite good glycemic control, very powerful compared to most of the oral therapies. And there's a lot of evidence, ample evidence on reduction of microvascular complications, and also there is no data to show increase in macrovascular events. But the key challenges of insulin therapy are the weight, hypoglycemia risk, and also the need of injections, where people with needle phobia might have issues. So if you look at individualization of insulin therapy, now we talk about individualized glycemic control and individualized treatment in diabetes, not just based on numbers. We need to think a lot in properly selecting the proper insulin type and the regime. And let me take you through some cases, And this is a standard, patient with 60-year-old long-standing diabetes on triple therapy with max doses of oral therapies, still not being able to control with high blood fasting and a high HbA1c. What is the next option? So the next option, when there is failure of oral hypoglycemic agents with high fasting blood glucose, would be best to give basal insulin replacement, and then what would be the best basal choice? There are a lot of basal choices. In our setting, the isophane is available. It's not a real basal insulin, it's a intermediate acting insulin. Then we have determia insulin, glargine insulin, degludec insulin, and then further I will elaborate some more newer long acting insulins. So this is the sort of glucose profile in this patient. Before adding insulin, you can see predominantly glucose is high fasting and in the morning hours. And so what we can do is to replace them with basal therapy while still on the sulfonylureas and other oral therapies. And this is called BITS therapy, and this is preferable because patient does not have major changes to their therapy and the regime, so the lifestyle adjustments are minimal. So these are the insulin that we have already spoken about, and this you can see a new insulin called insulin icodec. This is actually a once weekly insulin. So what happens before and after giving in isophane? You can see before and after. So when after giving insulin isophane, you get the fasting down, but throughout the day the control is not perfect but acceptable, and then particularly towards early morning the patient has gone into hypo situation because isophane is not truly a basal insulin, it's an intermediate acting insulin. So and any changes to now, we can think of determia, we can think of glargine, we can think of degludec and icodec. You can see this is a comparison of the insulin glargine and NPH in fasting plasma glucose and A1C control, more or less identical data. So there aren't much differences in the efficacy of glucose control. But if you look at these data comparing determia and glargine versus NPH isophane, there's ample data on the benefit of the longer acting analogs like insulin determia and glargine. You can see favoring glargine and determia on hypoglycemia reduction. And this is following determia 28 units after dinner. You can see now the patient is not having early morning hypos. But you can see still towards the latter part of the day, in the evenings, the sugars are high, showing that determia is not truly a 24-hour insulin. And then what are the other options to improve the situation? Here you see the glargine versus determia comparison. Particularly glargine is more longer acting and it has more 24-hour coverage. So if you give glargine here, you can get a more better control. Are there further better options? Insulin degludec is even longer acting. It is insulin where there is long attached to long molecular weight chains, and this is the sort of the degludec chains once you inject it, and so it is longer acting, and this gives even better control than glargine with lesser hypos. So what if this patient is living alone, unable to inject his or her insulin by herself? Then there is new insulins coming up. This is a once weekly insulin called icodec. There is a clinical trial you can see here published in the Diabetes Care, and it has shown that this is quite comparable in terms of HbA1c reduction, weight reduction, and not having hypos compared to glargine. So ladies and gentlemen, if you look at the contribution of fasting plasma glucose to postprandial glucose to the A1C, HbA1c relationship, particularly when your fasting blood glucose is very high, HbA1c is very high, the contribution from fasting blood glucose is very significant. And when it is low, the contribution from postprandial glucose for the HbA1c is much more than the fasting blood glucose. So the second case is like this: 62-year-old man, 9-year history of diabetes, complications with microvascular complications, hypertension, and on metformin, glimepiride, and on glargine, insulin 30 units. So still the blood glucose is not controlled. What are the options here? Now, here actually we can have these options to titrate the oral therapies, to add rapid-acting insulin like midday, we call it basal plus, or increasing the glargine further, or change into premix insulin. So if you can we move the slides? So if we actually increase metformin, glimepiride, or pioglitazone, you might not get the desired effects, but you might sometimes get complications with adding pioglitazone. Rapid-acting insulin is an option, we call it basal plus. Usually glargine can be increased further. Currently patient is on about 0.27 per units per kg. You can go up to about 0.5 units per kg. So now here this slide shows that increasing the glargine, the units per kg, the effect on the HbA1c, you can see when the number of units per kg is about 0.5, there's plateauing of the effect of the glargine on HbA1c. So you need to be aware of this in continuing the increasing the glargine. So giving a premix might be an option in this sort of situations, and another option may be to add midday soluble, or midday rapid acting, or basal bolus, and premix analogs. And here is what has happened following premix human insulin addition, which has again sort of controlled the fasting as well as pre-lunch, but the postprandial after lunch and the pre-dinner is still high. So the HbA1c might be suboptimal with the A1C 9. So what are the options here? In this sort of scenario, we have few options like adding midday soluble, midday rapid acting, or converting to basal bolus, or even giving 3 times premix analogs like a 50-50 combination. This is what will happen when we add midday soluble or basal bolus. Now here is a situation where we have added a midday soluble insulin. You have got pre-dinner hypos. So what are the options now? So if you add a more rapid acting insulin which acts faster and also dissipates faster, you can perhaps get away with this issue, because the action of this rapid acting analogs are shorter. Now the basal boluses also is a very good way of physiologically replacing insulin. You can see in the same patient, if you give a basal bolus regime, you can get almost all the readings nicely under control. You can individually titrate insulins. Now let's go as to another sort of scenario. Now here is a woman with obesity, partial lipodystrophy, and severe insulin resistance, needing 450 units of insulin per day. So in regular pen, you can give only a maximum of about 60 units and 100 units with the syringe. So the patient has to have multiple injections to get the sort of her single sort of insulin delivery for a time. So this is really inconvenient. So the concentrated insulins have been developed to answer this question and as a remedy. And here you can see a type of glargine where you have per ml 300 units. Usually the most of the insulin has 100 ml per 100 units per ml, but these concentrated insulins, now this one, the Humulin R, has 500 units per ml of soluble. So these concentrated insulins have slower absorption by different mechanisms. So when you need lot of insulin for a patient, this is an option to reduce the number of injections. Now here is a situation, a girl with type 1 who refuses food after taking the insulin, leading to hypoglycemia. How can you address this? Now here is a situation where you need to give very fast acting insulin, which can be sometimes, which can be given after meals or just before meals to increase the convenience. So this insulin combined with recombinant hyaluronidase is an answer for this, and there are insulins like Fiasp. Fiasp is a new insulin which is ultra fast acting analog. So you see the different insulins and their onset of peak action, particularly ultra fast acting insulins like Fiasp, and some inhaled insulins have very fast action. So you can ask the patient even to take insulin after meals. So this will improve the sort of compliance and improve the quality of life. And then this is a situation where there's an obese patient who gains weight and also has many obesity comorbidities, including obstructive sleep apnea and knee joint osteoarthritis. So if you give insulin, the patient's weight will go up. So we have actually now injectable combinations with basal insulin and GLP-1 receptor agonists like the IDEG-LYRA, where insulin degludec and liraglutide is combined, and in the Lixi-glagine is combined with lixasenatide, and you can see in this dual extension study, A1C reduction is superior for the combination of liraglutide and the degludec, and also the weight gain is much less compared to the insulin alone. But definitely when you give liraglutide, the weight loss is much more, but you can reduce the weight gaining effect of insulin by using GLP-1 receptor agonists along with insulin, and also reduces hypoglycemia. Because of these like complementary effects of GLP-1 analogs on the heart, the liver, GI tract, and the sort of very potent hypoglycemic effects of insulin, you can combine them with much better benefits than giving alone. And so here is a situation, a young child not willing for frequent jabs. What are the options? Although unfortunately we don't have these options like the closed loop systems and insulin pumps, we have to be aware these are becoming cheaper and more handier and much developed in technology. So we will have these options for our patients like insulin pumps. Can we get the slides going? And you can see with the pumps, you can adjust pumps to give multiple variable rates, so that things like dawn phenomenon and so on, where the people can get hyperglycemia as hypoglycemia at night, can be tackled by changing the basal insulin delivery at night. Again, this is, and particularly people with brittle diabetes, these pumps are very handy. And actually we are now getting to much more advances in the technology. Like you can see the older devices that we use for patients with diabetes, like the pens and the monitoring devices, but we have these very handy continuous glucose monitoring devices, CGMS devices, which are very small, can get a lot of information so that we can also optimize their therapies. And also we have this is, you see how the evolution of the self-monitoring of blood glucoses, but we have now these CGM devices have changed the way we manage and monitor glucose in the advanced countries, where it can reduce hypoglycemia. And there are even implantable CGM devices which can be kept up to about 6 months. So with just when the reader is brought close to the skin, it treats the blood glucose. And the flash monitoring is another advance, where you can have like a sensor kept for about 2 weeks, and then either the meter or a mobile phone with app is brought closer, it reads the glucose levels. And there are more advantages of flash monitoring, and particularly what I would like to emphasize is that when the blood glucose is going down, in people, those who are elderly or at risk of hypoglycemia, they can even send an alarm or call to another third party, which can prevent them from going into hypoglycemic coma. So the biggest challenge for many people using insulin pens is remembering the dose when they want to inject, and also whether sometimes even older people with dementia might forget whether they have already injected, and also on the insulin quality, whether they have been exposed to temperature, shelf life, storage conditions. And these smart insulin pens, which are also linked to an app, can also be very, very handy, shown to be very handy in remembering insulin doses, and also whether the patient has given insulin and the storage conditions, as well as particularly for people, type 1 diabetic patients who do carb counting and insulin dose adjustments. These apps can help you determining the amount of insulin to be delivered based on your carb quantity. So these are helping the people to improve their qualities of life, and they might even replace insulin pumps to some extent. And there are a lot of studies have shown the benefit of these smart pumps. And you can see a conventional pump with a lot of tubes, which will make it a hassle for the patient when you attach so much of tubes. But again, things are improving, like these hybrid systems where a pump is attached to the CGMS device, and they can communicate via Bluetooth technology, and with various algorithms can help the titration of the blood glucose, and particularly prevent people from going into emergencies, both hyperglycemic and hypoglycemic. And further advancement of the pumps have shown that this Omnipod 5 is a tubeless pump. You can see it can be kept for several weeks, and even patient can go for swimming and so on, combined again with the CGMS device in closed loop technology, which will also really transform the lives of people with type 1 diabetes, acting like an artificial pancreas. So those who mostly benefit from new technology are those with type 1, children, pregnancy, and people with hypo-unawareness and brittle diabetes. So ladies and gentlemen, I have told you that the insulin is life-saving in type 1, and then the guidelines recommend therapy when there is failure of oral therapies or when the A1C is more than 9. We need to start with simple regimes like basal insulins, and the newer basal analogs have slight advantage on reducing hypos compared to NPH. And then the next option when the basal therapy fails is to give either premix or basal plus therapy. And then the newer technology like the CGMS devices, pens, pumps is also transforming the insulin therapy in a very, very user-friendly manner. But you need to individualize your glycemic targets, and important to consider the availability and also other socio-economic considerations like the social determinants in selecting appropriate therapy, appropriate technology to our patients. So we need to also not forget to promote continuous adherence to healthy diet and physical activity and prevention of hypoglycemia in our education programs on insulin therapy. And we need to be enthusiastic and confident and encourage and empower our patients so that they can have best utility, best use of whatever the insulin we use on them. Thank you very much.
Thank you very much, sir, for that comprehensive overview. Next, we have another very, very important topic. This topic will be discussed by Dr. Udita Bulugahapitiya, consultant endocrinologist at the National Hospital of Sri Lanka. So we'll discuss about the diabetes complications and how to prevent, detect, and refer timely and wisely.
morning to all of you. uh, Slides, please. Slides. Right. Good morning to all of you. In next 20 to 25 minutes, I'm going to talk to you about diabetes complications. In my session, I like to go through a few words about it's not moving. Right, okay, sorry. In my talk, I'm going to talk to you about diabetes and how to prevent all the complications, initially macrovascular and microvascular complications. Then I'm going to go through about painful neuropathy in diabetes, how to manage, and then few words about retinopathy and microalbuminuria and how to manage that, and then nephropathy and high creatinine, how to manage, and also diabetic foot disease also to a certain extent, and then I will go through a few conclusions. Ladies and gentlemen, all of you know that diabetes gives you multiple complications, and majority of the patients with diabetes will die from a heart attack or a stroke. There is about 2 to 4 fold increase in getting a heart attack or a stroke when you have diabetes. And also other complications, common ones are like diabetic nephropathy, diabetic neuropathy, and diabetic retinopathy. I'll try to go through them very shortly. This to just to show you that patients with diabetes are going to die mainly from a heart attack or a stroke, and therefore the mortality, 60% of the patients will die from heart attack or a stroke. With that, ladies and gentlemen, I'm going to go through cases and going through with you. This is a 52-year-old gentleman having diabetes for 4 years, hypertension for 6 years, dyslipidemia for about 6 years, and also having a strong family history of ischemic heart disease. On examination, his blood pressures are slightly up, 150 by 90, and he is on medications like metformin and nifedipine, and also on atorvastatin. So HbA1c is 8.1, and their microalbumin and other basic investigations are normal. There is slight elevation of liver functions, probably due to fatty liver disease. So in summary, this patient is a 52-year-old male, diabetes for 4 years, hypertension for 6 years, which is poorly controlled, both diabetes and hypertension poorly controlled, and dyslipidemia 6 years, and also lipid profile shows LDL cholesterol is around 130, 140, it's also not well under control, and liver enzymes showing fatty liver disease. Now also having a strong family history. Now how do you manage this patient to prevent complications like macro and microvascular complications, and also how you reduce the death from stroke and heart disease? Now the most important thing here is to have the glycemic target for these patients to avoid micro and macrovascular complications. Then the blood pressure target to make sure that the patient doesn't get these complications, and also cholesterol management, and whether the patient needs aspirin, or not. So for the glycemic control, we know that this patient has got HbA1c of 8.1. So how do we go ahead with this? Now the patient is on metformin and nifedipine and atorvastatin. Now if you look at a few studies that shown the HbA1c and the complication reduction, it's very clear that the majority of the studies have shown reduction of the HbA1c, reduce the cardiovascular risk as well as the microvascular complications. But what we know is that when you reduce the HbA1c, you are 100% getting a cardiovascular risk reduction, 100% get the microvascular risk reduction, but macrovascular risk may not be reducing with the HbA1c reduction. But for you to reduce all the complications in diabetes, you probably should try a reduction of HbA1c to a acceptable level. Now ladies and gentlemen, if you get a newly diagnosed type 2 diabetes, try to have aggressive control at the initial stage of the disease. That will reduce your micro as well as macrovascular complications. In this particular patient who has got diabetes for about 6 years and hypertension, dyslipidemia and so on, the best glycemic control in the majority of the patient is 7. And if you get a newly diagnosed, get about 6.5 if the hypoglycemia is not a problem. So this patient's HbA1c should be around 7. Fasting or a pre-prandial blood sugars can be less than 130, or a post-prandial blood sugar can be less than 180. So if you can achieve this, probably the patient may not get complications of micro and macrovascular complication in the long run. Therefore, try to do achieve the targets. So what about the blood pressure in this patient? Now blood pressure is about 150/90 in this patient. Now if you look at this slide, I'm just going to show you. Red you will see blood pressure, and the yellow you will see the blood sugar. When you have a blood pressure and blood sugar in a patient, more important is actually to control the blood pressure than the blood sugars. And this is very clearly show that if you want to reduce strokes and any cardiovascular outcomes or diabetic outcomes, what you need to do is to get a pressure control 100%. So I think this is very important in all the diabetic patients. Try and get the pressure control maximally. So what is the blood pressure target? 140/90, less than that, to get the best target. So if you can achieve 130/80 in this particular patient, you probably will prevent getting microvascular complications and to a greater extent getting prevention of the macrovascular complications. So try to get our patient's blood pressure less than 140/90. What about the lipids on this patient? Whether you are going to how you are going to manage. Now when you look at the lipid targets, we know when you have diabetes, there is a triad of lipid issues in patients with diabetes. One, majority of the patients can have LDL normal or high. Then you can have a HDL low and a triglyceride high. This is usually you get the triad into diabetic patients. LDL, HDL can be low, triglyceride can be high. So our patient also has got high LDL in this patient, so about 140. So what can we do? So our patient is like 50 years of age. Now if the patient is more than 40 years of age, majority of the patients will benefit from a statin. So you can start a statin after 40 years of age. But if the patient has already having a cardiovascular disease or a risk of cardiovascular disease, you need a high intensity statins. That means you can have about atorvastatin 20 or rosuvastatin 10 kind of a dose. So majority of the patients more than 40 years, you start a statin, you can reduce your cardiovascular risk as well as microvascular complications. Important thing is less than 40 years of age. If you have a less than 40 years of age without any cardiovascular risk factors, patient needs no statin. But if the patient has multiple cardiovascular risk factors, so overt cardiovascular disease, then think about starting a statin. So I think it's important that you start a statin correctly on these patients to reduce the complications, especially the macrovascular as well as the microvascular complications. Therefore, now you know about the HbA1c target, now you know about the blood pressure target, and hope you know how to start the statins in patients with diabetes, and what about the aspirin for this patient. Now, when you look at aspirin, you know, majority of the studies have shown aspirin is beneficial when you have multiple cardiovascular risk factors, not the patients who doesn't have cardiovascular risk factors. So if you look at this, you will understand that if the patient has already having a cardiovascular disease, when in a diabetic patient, those patient needs aspirin continuously. There is no doubt about it. But when the patient is having diabetes without a cardiovascular disease, then if you have one more cardiovascular risk factors after 50 years of age, you can start aspirin. So ladies and gentlemen, it's important that all the patients with diabetes needs no statins, no aspirin. Aspirin is indicated when the patient is more than 50 years of age with a one additional cardiovascular risk factor. So then you know how to start aspirin, you know how to start statin, then how to get the HbA1c and a pressure control. And this particular my patient here, which I have shown you, need a lifestyle modification in order to prevent the microvascular as well as macrovascular complications. With that, I'll go for the next case. The patient is 62-year-old, having diabetes for 11 years, hypertension for about 4 years, and this patient is complaining of burning lower limb pains. So this is an important finding of this. If you look at the investigations, blood pressures are quite okay, and patient is on metformin 1 gram twice a day, glibenclamide 10 milligram twice a day. Now also this patient shows some other poor glycemic control, and other parameters are normal. So ladies and gentlemen, in summary, this patient has got 62-year-old male, non-smoker, poorly controlled diabetes for 11 years, on 3 oral agents, hypertension well under controlled, having painful neuropathy, complaining of painful neuropathy. So how do you manage this patient? Now, all of you know about the glycemic target. You have to get the HbA1c target to 7, and I know previous speaker has spoken to you how to get it there with other medications, and how to manage painful neuropathy in this patient. So it is very, very important to understand how to manage the painful neuropathy, which is disabling for this patient. So when you look at the diabetic neuropathy classification, you know there is a condition called rapidly reversible neuropathy, which is due to poor glycemic control. When you have high blood sugars, they can get severe pain in the legs with a painful neuropathy, which is a reversible neuropathy in diabetes due to poor glycemic control. Then you have a generalized symmetrical peripheral sensory motor neuropathy in diabetes. Majority of our patients are having this. It can be more sensory or more motor when they present to us. So majority of the patients are having symmetrical sensory motor neuropathy in diabetes. It should be always symmetrical as well as distal. So they also can have focal and multifocal neurological involvement, which is sometimes we see 1 or 2 nerve involvement. So this is the classification for neuropathy in diabetes. So our patient has got painful neuropathy. It can be due to hyperglycemia itself, because then the high blood sugars, the pain is get worsen. But then what you need is to control the blood sugars with the tight glycemic control. That itself can reduce the pain in reversible painful neuropathy. Then you get a chronic sensory motor neuropathy. Probably our patient is having mainly a sensory painful neuropathy, which is chronic, and these patients also need good blood sugar control, blood pressure control, statins, and lifestyle modification, and the specific treatment for neuropathy. Now when you have diabetic neuropathy, first thing is to good glycemic control, and then the symptomatic treatment to reduce the pain or whatever the neuropathy you are talking about. Then agents to restore and improve the nerve function that you need to understand. Then avoidance of the nerve toxins is very, very important in clinical practice. Now this is a more important slide which I want to show you how to manage painful neuropathy. There are 3 categories of medications that you can use. One is a tricyclic antidepressants. You use amitriptyline most of the time. Then you have serotonin reuptake inhibitors, and you can use voltage gated calcium channel blockers. So one thing is that you can start one medication, like if you start amitriptyline, you can go into the maximum dose of amitriptyline, and if the pain still persists, you can add the next first line medication, pregabalin, gabapentin or duloxetine. So you can go on a combination after that. Also, there are second line medication for painful neuropathy, which is opioids and the tramadol and kind of things, but you can use very rarely. But majority of the patients, when you use these medications properly, they won't get any problems in neuropathy. So neuropathy is an important reversible treatable condition in type 2 diabetes, which you can simply treat this patient without much of a problem. In third case, ladies and gentlemen, 60-year-old patient having diabetes for about 10 years, and if you look at the other parameters are all normal. Medications are metformin and glibenclamide again, and if you look at HbA1c 7.5, not that great but not too bad as well. And if you look at the patient has got microalbuminuria, so elevation of microalbuminuria with a normal creatinine is the problem here. So if you look at the summary of this case, 60-year-old female, diabetes for 10 years, need better control, have some retinopathy, but having urine microalbumin with normal creatinine is the issue. So majority of our clinic patients are having this problem. When they develop microalbumin, how do we treat this microalbumin? So what about microalbumin treatment? What about blood pressure target? I've already discussed about the blood pressure targets. So how to treat the microalbumin? So ladies and gentlemen, when your urine albumin is between 30 to 300, you call it microalbumin. Then you can go into the overt proteinuria, and this is normal albuminuria. But newer classification is like increased albumin excretion when you have more than 30 and less than 30 considered as normal. So when you do a urine microalbumin, if it is more than 30, then you need attention, you need treatment for these patients. How do you treat? First is the blood pressure control is very important. If the patient has high blood pressure, start controlling them, preferably starting ACE inhibitor or a ARB blocker. Next medication that you used is a calcium channel blocker. So that's the way that you should start this patient's treatment. And if the patient also needs, when you have a microalbumin disease, lipid control is extremely important, and also the glycemic control is extremely important. But when you have a microalbumin, high microalbumin, protein restriction is not necessary. There is no data to support that. But what you need is the blood pressure control with appropriate medications, and also glycemic control and a lipid control is the most important thing. So when you have a patient with diabetes, they can progress to microalbumin disease, then you can go into macroalbumin disease to end-stage renal disease. So what you should try to do is prevent patients going into diabetes into the microalbumin stage. So what you need is that tight glycemic control, tight blood pressure control, lipid control, and the lifestyle modifications to avoid patient going to the microalbumin stage. From microalbumin stage again to the macroalbumin stage, same treatment options. You have to make sure good glycemic control, hypertension control with ACE inhibitor or ARB blocker, or next is the calcium channel blocker. And when they develop microalbumin disease, again the same measures to prevent patient going into the end-stage renal disease. Therefore, ladies and gentlemen, when you patient try and avoid getting microalbumin disease, how you do that is a good control of pressure, good control of diabetes, good control of lipids. And when they develop microalbumin urea, then you have to work hard to get on, not to get into the end-stage renal disease. When they develop end-stage renal disease, then you need to work more towards that. So in case 4, a 60-year-old patient who has is a non-smoker, underwent a cataract surgery earlier, and if you look at here, the patient has developed non-proliferative diabetic retinopathy, and non-proliferative diabetic retinopathy, and yeah, just show you that diabetic retinopathy. and the patient has got diabetic retinopathy. When patient has got diabetic retinopathy, patient needs a referral to a tertiary care center or an eye surgeon, and the most important thing is the treatment from a specialized center. And majority of the patients will have no symptoms when they develop the disease, and they need to refer into the surgical eye surgeon's unit for further management. Majority of the patients may need laser treatment, and therefore can prevent getting into the blindness. Majority of the patients with type 2 diabetes get the blindness without any symptoms. Therefore, at least yearly you need to refer these patients timely onto a eye surgeon, or at least yourself you need to look at these patients properly. Now a few words about diabetic foot disease. We all know that diabetic foot disease is important aspect here, and if you look at lifetime risk of developing a foot ulcer is about 25% in a diabetic patient. So 1/4 of the patients can develop a foot disease and an ulcer. Now, limb amputation is around 10 to 30 times more common in diabetes when you compare with the other population. Huge risk of losing a limb. 85% of the limb amputations in diabetes follow an ulcer. So whenever you see an ulcer, we know that 85% of these patients will end up in a foot amputation. And if you go further, you will understand foot ulceration is the commonest hospital admissions in diabetes. So that is well established, and it is very, very expensive to treat. Therefore, ladies and gentlemen, you have to try and prevent foot ulcerations. After amputation, 30% of patients will lose the other limb in 3 years' time. So it's like a huge problem. After amputation, 2/3 will die in 5 years. It's worse than many of the cancers. If you see a patient with one amputation, probable duration is less than 5 years. So it's a huge, like a cancer. Therefore, you need to understand this important point. So further into the pathways of how you develop the diabetic foot ulcer, it's very, very important. When you develop a neuropathy, it can be either motor neuropathy, sensory neuropathy, or autonomic neuropathy. With the motor neuropathy, what you get is the deformity in the foot, and sensory neuropathy causes callus formation in the foot, and the autonomic neuropathy causes dryness and cracking of the foot. So it is very, very important to understand this pathway. And all these three, whenever you have a minor trauma, can give rise to ulcer, which can persist and end up with a amputation. So this process need to be understandable. And then poor vision can worsen this problem. Poor vision can cause minor trauma, which can give rise to ulcer, and also poor self-foot care, which can also worsen this problem and make a ulcer in a diabetic foot. And a poor glycemic control we are taking up from that place onwards until the patient will get worsen the ulcer and the amputation. So this is the process, ladies and gentlemen, that you will get a ulcer and end up with a amputation. So we need to stop into this. Few things about neuropathy. I'm not going to go into detail, but sensory, motor, autonomic neuropathies are the three types of neuropathies. Now this photograph I am showing the cracking of the feet. This is due to autonomic neuropathy causing dryness of the feet. So we can avoid this by giving a cream which can be applied at least twice a day or once a day. Now this is a hammer-toe deformity, which is due to motor neuropathy, which is causing this deformity in the feet. Now this is the callus formation is due to the persistent pressure due to the sensory neuropathy, which can give rise to a callus. Callus is the one which can give rise to a ulcer later and causing for amputation. So these are important photographs that I have shown you. As also, this can also see that there is a pressure effects from the shoe, which can give rise to a cellulitis and ulcer later on. So ladies and gentlemen, with that I want you to understand what are the precutaneous ulcer pathology. So when you see these things, you know that patient is going to get ulcer. One is persistent erythema of the feet. You have to look it whenever you see a patient. Callus formation is a precutaneous pathology, and a callus with subcutaneous hemorrhages are high risk just before formation of a wound. Then a fissure in between toes is a precutaneous ulcer formation, and also interdigital macerations and fungal infection of the feet, and also the nail pathology. When you see those things in your patient, you know that the patient is going to get ulcer, and therefore you have to be careful. So diabetic foot examination should be at least carried out once a year on each and every patient, and it takes about 3 minutes if you do a proper diabetic foot examination. When you do that, it's important that you look at the dry skin, absence of hair, ingrown nail edges, long and sharp nails. Also examine the foot carefully, and also look at the deformities. If the patient has developed all these deformities can give rise to ulcers. Also inspect the footwear always in order to make sure that the footwear is suiting the patient properly. So diabetic foot examination, you have to look at the peripheral pulses, dorsalis pedis and the posterior tibial. If one is present, there is no evidence of any vascular problems. Then the 3-point sensory examination with a monofilament, you can use only 3 points here, which is more than enough to assess the sensory neuropathy of the feet in diabetes. The vibration tool, you can use it again to look at the vibration tool for the sensory neuropathy, and this is also simple method that you can use it in the ward. Other one is the biothesiometer. If you have got biothesiometer, you can use it. If the vibration perception is more than 25 volts, then you know there is a problem. But ladies and gentlemen, you need not to have all three in order to assess the risk foot. But what you need is at least 1 or 2 of them. If you have, then you can look for assess this. So all the individuals with type 2 diabetes need to have foot examination at least yearly. And if the patient has high risk foot, especially if the patient has past history of foot ulcer, a spontaneous ulcer, or an amputation, the patient becomes high risk. Then the patient needs to be looked into 3 to 6 months. But if all the sensory, motor and other things are intact, then the patient is extremely low risk, and patient can be examined yearly. Other patients, you can moderate risk patient can be examined in between. Therefore, ladies and gentlemen, in conclusion, I think the more important thing is to avoid getting complications in diabetes. So have a multiple risk factor approach from the starting of type 2 diabetes or a type 1 diabetes. Then you can prevent micro and macrovascular complications. At least in your practice, do an annual end organ screening, and then appropriate timely referrals to eye surgeons, and if there are foot issues, to a vascular surgeon that can avoid getting complications. Specialist opinions are needed when the patients are developing renal disease, like when the patient is getting increased creatinine, and also the patients developing retinal issues, as well as patient developing foot problems. And during those times, patient needs a specialized opinion in order to prevent further complications. So I think the best thing is to avoid complication by appropriate treatment. Thank you.
Thank you very much, sir, for that excellent lecture. Next, we have 2 speakers who will address the frequently asked questions in the diagnosis and management of diabetes. So first, we have Dr. Gauri Ratnayaka, acting consultant endocrinologist at National Hospital of Sri Lanka, and she will be followed by Dr. Dayakshi Aberatna, senior registrar in endocrinology, National Hospital of Sri Lanka. Over to you, Dr. Gauri.
Thank you. Thank you very much for those kind words of introduction. So my task today is to answer some frequently asked questions in diabetes. So I would like to begin with the question, what glycemic targets that should be achieved in patients with diabetes? Well, so the glycemic target should be catered to individual patients, and there are several factors that we consider when we are setting up glycemic targets for a patient. The first would be the risk of hypoglycemia, then the duration of the disease, potential life expectancy, and presence of comorbid conditions. And personal preferences and social and financial circumstances. So we would like to recommend an HbA1c target of less than 7% for most of our patients. However, if the when a patient has a lot of comorbid conditions or whether their life expectancy is short, then we try to relax our HbA1c targets and would like to set up a goal of around an 8%. So all in all, the glycemic target should be catered to the individual's needs, and patients should be managed accordingly. The second question would be monitoring patients with diabetes, what tests and how frequently we should test them. So, monitoring diabetes not only include monitoring their glycemic control, but it also include monitoring for target organ involvement. So, when it comes to monitoring glycemic control, we nowadays generally recommend self-monitoring of blood glucose. Apart from that, fasting blood sugar is a popular parameter that is being used in our clinics. And we also prefer to do HbA1c because it assesses the glycemic control over a period of 3 months. In addition, in selected patients, we also recommend ppbs values. So how frequently should we monitor these patients? Well, if the treatment goals are being met, then the glycemic status should be assessed at least twice yearly. However, if we are unable to meet the treatment goals, or if the therapy has been changed recently, then glycemic status should be assessed at least quarterly. When it comes to the target organ involvement, we are worried about diabetic kidney disease. Therefore, all the patients should undergo a urine albumin creatinine ratio and an EFR at the diagnosis in the case of type 2 diabetics, and at least within the first 5 years of treatment in a type 1 diabetes. And if the urine albumin creatinine ratio is more than 300 milligrams per gram per creatinine, and or the eGFR is between 30 to 60, then they should be monitored twice a year. When it comes to the retinopathy, again, the type 1 diabetes patients should be screened within the first 5 years of diagnosis, and type 2 diabetes patients should be screened at the diagnosis. And if there's no evidence of retinopathy, in at least one eye examination, then screening again should be carried out every 1 to 2 years. When it comes to monitoring for peripheral neuropathy and diabetic foot-related complications, again, the patients with type 1 diabetes should have a foot assessment within the 5 years of their diagnosis, and type 2 diabetes patients should have a foot assessment at the diagnosis. If there's no evidence of neuropathy or prior ulcers or amputations, then you could offer them reassessment annually. However, if the patients have or has had any of these issues, then they should be assessed at every visit. So next, let's move into the important question of how do you adjust the dose of metformin according to the renal functions. So when it comes to metformin and chronic kidney disease, it is important to educate the patient by saying them that metformin does not cause kidney disease. However, we recommend to discontinue metformin if the estimated GFR is less than 30 ml per minute per body surface area, and the metformin dose should be reduced, and as well as it should be reassessed, comparing the risks versus benefits when the GFR lies between 31 to 44 ml per minute. Temporary discontinuation of metformin is recommended if a patient is undergoing any studies which involved iodinated contrast media and their eGFR falls between 30 to 60 ml per minute per body surface area. So the question number 4 is, what are the cholesterol targets for patients with diabetes? Well, lipids targets for patients with diabetes are being set up according to the risk category. So how you risk stratify the patients with diabetes is by assessing whether they have evidence of target organ damage, or whether they have the duration of the diabetes. So for a high-risk patient, we would like to keep their LDL levels less than 55 milligrams per deciliter. And for a moderate risk individual, it would be less than 30 milligrams per deciliter. And for a low risk individual, it could be less than 100 milligrams per deciliter. So according to meet these targets, you should adjust your statin doses, and also you might have to start them on alternative dyslipidemic agents. Then when it comes to patients with diabetic nephropathy, what should you do when you see a patient with diabetic nephropathy? So peripheral neuropathy is a common microvascular complication in diabetes, which leads to a significant increase in morbidity and mortality. And it is important to optimize the glucose control in these patients, because optimizing glucose control is known to reduce the progression of peripheral neuropathy. And it is also important to perform a detailed foot examination so that you can identify the patients with high-risk diabetic foot and take appropriate interventions to minimize further complications. And it is also important to educate the patient and empower them on diabetic foot care. So finally, you may prescribe certain medications to relieve symptoms associated with peripheral neuropathy. For an instance, for people with painful peripheral neuropathy, the first-line agents that we generally prescribe include duloxetine, gabapentin, or pregabalin. Then if these medications are unavailable, or if they are not tolerable by the patient, then you can go for the second-line options like amitriptyline. So the next half of the lectures would be conducted by my colleague, Dr. Dayakshi Aberatne. I would like to invite Dayakshi to continue with the presentation. Thank you.
Audible. Thank you, Gauri. The next half of the presentation with the frequently asked questions will be done by me. I'm Dr. Dayakshi Aberatne, one of the senior registrars at the National Hospital, Sri Lanka. I cannot see the presentation. All right. Next, please. Okay, so the next question I'm going to elaborate on is, when do we prescribe insulin in a patient with type 2 diabetes, and what seems to be used? And if you were throughout the webinar, Dr. Katulanda's lecture gave a very elaborative description about this question. Next, please. Next slide. So the most important thing is when we want to start a patient on insulin to break the the therapeutic inertia, like the reluctance to start on insulin. The most important thing is when should we start on insulin? It is, as for the recommendations, it's if the HbA1c remain uncontrolled even after 3 months of triple oral agents, or if the HbA1c is anyway more than 10 onset, and if the blood sugar is more than 3 milligrams, or if the patient is having symptomatic hyperglycemia, at those points we have to change over start the patient on insulin treatment. And we are reluctant to start on insulin treatment due to multiple factors, patient as well as the physician factors, because mostly because of the things, it is an injection therapy, and there's needle phobia, and there's a risk of hypoglycemia, and also in countries like Sri Lanka to store the insulins properly, and the cost of insulins if you are going to newer types of insulins. So however, we have to know that starting insulin early is very important. That's also elaborated to prevent microvascular and macrovascular complications. So the initial starting dose as a guidance is we can start off with the basal insulin, and it could be 10 units per day, or it could be 0.1 to 0.2 units per kg per day, and this could be adjusted on weekly or twice weekly, assessing the fasting blood sugar control. And this could be adjusted by 2 to 4 units or 10 to 15% of alterations. And what kind of regimes that we can use, I will elaborate in the next slide. Next, please. Next, please. So I'm not sure whether the slide is clear to you, but what we can do is we can start off with the basal insulin, and the basal insulins in Sri Lanka, either it could be isophane insulin, which is not a correct long-acting type of insulin, it's an intermediate insulin, but we can start off this NPH or isophane insulin. Can start on an insulin glargine as a nighttime dose, and alterations are being, once we continue on the treatment, there is a risk of hypoglycemia in patients who are receiving NPH than patients who are receiving glargine insulin as a once daily dose. So other once daily basal insulins are insulins like insulin degludec, insulin detamir, or insulin detamir. But usually insulin degludec has lower, like lesser hypoglycemic risk compared to the other insulin types. But in our setting, what we have is isophane, NPH, and mostly insulin glargine and insulin detamir. So what happens is, after starting on a basal insulin while continuing the oral agents, we can reassess, and if we are still not meeting the targets, the desired insulin targets, we can either introduce a mealtime insulin to cover the main meal, or the other things we can do is change over to pre-mixed type of insulins, like twice daily pre-mixed insulins. And also the other one is to add a GLP-1 receptor agonist, which is also costly in our setting. And the other next step of changing over the insulin therapy is either to change these patients into basal bolus regime, where the mealtime insulins are given as with the basal in the night, which is actually associated with a very nice glucose control. But due to the reason that it has multiple injection doses, we are always trying to go with the pre-mixed initially, or with the once daily basal insulin at the background. Next slide, please. So the next important thing is, like always, the patients also ask, can insulin cause weight gain? Of course, the reason is insulin is a hormone that causes that utilizes extra glucose in the body to store as fat, or store as energy, or utilize as energy. So when the patient is having extra calories, when there is enough insulin in the body, they will store this extra glucose as fat in the tissues. So this can happen in both type 1 as well as in type 2 diabetes. So to minimize weight gain associated with insulin, we encourage to have a proper dietary control with the only the daily requirement of the calories, as well as to have a regular meal pattern, and also to time the insulin with this regular meal time pattern. So the peak of the insulin action is associated with the glycemic increase in the after the meal. And the other most important thing that the researchers have found out to reduce the weight gain associated with insulin is to have the regular exercises as advised for other diabetes patients, like the 30 minutes. Sorry.
Workshop
The next question, so that's about it. And the next question is, when should a patient with diabetes and proteinuria or renal impairment be referred to a nephrologist? Next slide, please. This was also elaborated in a previous lecture. Most important thing we have to know is this is a common encounter, especially as medical officers in the clinic setting. There are lots of patients with different stages of CKD, or different creatinines, or different albuminuria. And so what we need to know is, like, definitely we have to refer the patient to a nephrology team if we think that this worsening of EGFR is EGFR, or this increase in proteinuria is diabetes. One thing is if they're rapidly worsening EGFR as well as the proteinuria, because in the diabetes it's sort of a slower progression. And also detecting an active urinary sediment, which means, like, if we do a UFR and if we get a red cells in the UFR, and if you're thinking like that, if there's no any urinary stone disease or urinary infection concurrent after detecting this red blood cells in the urine, we have to check whether it has dysmorphic red cells, which will give us an idea whether there is an active urinary, whether it's an active urinary sediment. And also, if the patient, especially in type 1 diabetes, if the patient is having nephropathy without retinopathy, again, we have to think whether this is another some other cause. And the other thing, if we are sure that the patient is having diabetic nephropathy, at what point should we refer to a nephrologist? Is the current guidance is if the EGFR goes below 30 milliliters per minute per 1.73 square meter body surface area. So if it's less than 30 EGFR, we have to refer to a nephrology team. The other thing is, if the patient is having albuminuria, which is severe albuminuria, which is severely increased albuminuria of more than 300 milligrams per grams. And these two are the clear-cut indications, less than 30 of EGFR and more of albuminuria. And the other, whenever even at the midpoints, like say the EGFR is between 30 to 40 also, if you have a query, if you think this CKD level is associated with hyperkalemia and renal anemia and complications, or the bone disease or hyperparathyroidism, or increased phosphates, even if the EGFR is not less than 30, you may want to discuss first with the experienced physician in the care of kidney disease or endocrinologist, and then also with the nephrologist with that regard. Next slide, please. Next slide, sorry. So this chart, I'm again not sure whether I think it's clear. So whenever you're not sure whether you need to refer the patient, you can always go back and refer to this chart as well, which is in the American Diabetes Association guideline, which also clearly depicts when you should refer a patient. As you can see, when at the cornermost cage, you can see, like, if severely increased albuminuria is there more than 300, despite the EGFR level, you have to refer the patient to a nephrologist. And as I said, usually less than 30 of EGFR, you have to refer to a nephrologist. Next slide, please. Thank you. So the 9th question is, when the patients have pre-diabetes, should they be started on metformin? Next slide. So pre-diabetes, next slide, yeah. So when we consider pre-diabetes in a patient is when the HbA1c is between 5.7 to 6.4, or the fasting blood sugar between 100 to 126, but this cutoff could be different in UK, which is 110 to 126 milligrams per deciliter. So the importance of identifying the category of patients in pre-diabetes is that can progress into type 2 diabetes later on, and whatever the actions we take now will prevent or delay the progression of pre-diabetes to type 2 diabetes. So our question was whether to start on metformin. Metformin can be considered in only some population, but the whole population of pre-diabetes people should be started on intensified alteration of their lifestyle. So which means they should target to maintain, they should target to reduce and maintain a 7% loss of initial body weight, and also to increase the moderate intensity physical activity to at least 150 minutes per week. So this reduction and maintenance of 7% of body weight was after multiple researches that they have found out this value. And as well, what is in the guideline is that we have to refer the patient to a proper lifestyle behavior change program or for a weight reduction program. And also we have to tightly monitor to see whether this target is achieved. And the other thing is, the most important thing is to do 150 minutes exercises per week, where 150 could be 30 minutes per day for 5 days per week. And with all the findings, they have found that even if you don't achieve the target of 7% of body weight loss, the ones who are doing this 150 minutes exercises have 44% reduction of going into type 2 diabetes later on. So exercise per se is also very important. And apart from that, metformin should be considered in patients with pre-diabetes, especially if the patient's body weight is more than 35 kilograms per square meter. This is the American cutoff, but when it comes to Sri Lankan cutoffs, of course, 30 to 35 also, we can take a decision on starting on a metformin for pre-diabetes. And the other thing is the patients who are less than 60 years with this high BMI, also separately in patients who have had a history of gestational diabetes, they are more prone to progress into type 2 diabetes. For them also we can start on metformin. Next slide, please. So the last question is the glucometer assessment of capillary blood glucose at home, are they always accurate? Do patients need to check venous blood from laboratory from time to time? Next slide, please. So now most of the glucometers that are used even in Sri Lanka, they are mostly validated. So most of the time we can believe in the glucose values that comes in the glucometer, capillary glucose monitoring. And we should always encourage the patient to use unopened, unexpired glucose strips. And only when the glucose values that comes in the glucometer is discordant to the clinical reality, say like a patient is getting low values, very low values without having any symptoms of hypoglycemia. That can also happen in reduced hypoglycemic unawareness, but if it always happens, it's better to check it, cross-check it with the lab value. And also if we think like the glucose monitoring levels are not tallying with the 3-monthly HbA1c level, then also we can get it tested. Otherwise, annually or once in 2 years, we can also get it validated by cross-checking with the lab value. And also it is very important to know that in a country like Sri Lanka, only a limited population can afford for a glucometer, and especially for the glucose strips because they are very expensive. And it is very important when they use a glucometer and when they test a blood sugar level that we interpret it and do some adjustment for their management. And also it is important to empower them to make the adjustments according to their self-monitoring, according to the self-monitoring blood glucose data, how to adjust their insulins accordingly. That is very important because they are spending a lot on measuring these blood glucose levels as well as for the glucometer. And I think we have come to the end of our session. Thank you very much. I will hand over the session to the moderator here onwards. Thank you for listening. Thanks.
Thank you very much, Dr. Dakshi and Dr. Gauri for that session. The next item in today's program is another very important topic for any practicing doctor. So the topic of the next session is management of diabetic emergencies, diabetic ketoacidosis and hyperglycemic hyperosmolar state. This topic will be discussed by Dr. Sonali Gunatilaka, consultant endocrinologist at the Provincial General Hospital of Nuwara.
A very good morning to all of you. I hope my slides are visible to you. Okay.
Yes. Yes.
All right. Okay. Right. So this is regarding diabetes and diabetes emergencies. So without further ado, let's move on. During this talk, I will be covering on diabetes ketoacidosis and hyposmolar hyperglycemic state, which are very important for MOs, senior registrars, consultants, and any of the medical profession to identify these and treat properly, because these conditions carry a lot of mortality and morbidity, and we can save these patients if correctly identified and timely managed. Okay. So my talk is based on JBDA's guidelines. These are UK guidelines, and I must tell you that the guidelines do differ from country to country. Guidelines, and we might alter according to the availability of resources. So I'll go through a few cases, 2 cases basically, and take you through the management of these conditions through the cases. So first case is 32-year-old previously healthy lady presents with abdominal pain and vomiting. Attitude basic evaluation shows normal GCS with moderately dehydration and tachycardic, BP is stable, and capillary blood sugar of 450 milligrams per deciliter. She's a previously healthy lady. So this lady comes up with high sugar levels and she's dehydrated. If you are the doctor looking after this patient, what are you going to do? What is the diagnosis? So the immediate thing with high sugar levels is, if we take emergencies in a relatively young lady, it should come to your mind that, is this DKA, diabetes ketoacidosis? Okay, what is diabetes ketoacidosis? It signifies the 3 names. Diabetes is hyperglycemia, high sugar levels. Ketoacidosis. Keto means ketosis, high ketone body levels. Acidosis is, you and I both all know, it's acidosis. But to diagnose diabetes ketoacidosis, you need to have all 3 components. Individually, these components will be there in different other conditions. But it's not just hyperglycemia and acidosis, not just hyperglycemia and ketosis, not just acidosis and ketosis. You need to have all 3 components to diagnose diabetes ketoacidosis. Okay, provided we have all these components, but we should have cutoffs for diagnosis. So we have these cutoffs, and we need to check these in order to make a proper diagnosis and not to miss diagnosis of DKA. So they are ketonemia, that is if the blood ketone bodies are more than 3 millimole per liter, or in clinical setup, if you don't have blood ketone meters, urine ketone bodies equal or more than 2+. And when the glucose, capillary glucose or blood glucose level is more than 200 milligrams per deciliter, and serum like venous or arterial bicarb level is less than 15 millimoles per liter, and or pH less than 7.3. So all 3 components are important for you to diagnose DKA. A little bit about capillary ketone meters, because we usually do urine ketone bodies in the peripheries and also in the main hospitals as well in Sri Lanka, but still now we have capillary ketone meters, and these are being used in main centers. It's quite quick, because even if you do urine or serum blood ketone levels, it would take hours, and you can't wait hours to diagnose these patients and start treatment. So these are commercially available now. Some are in government hospitals. Please try to use them if you have the facility. If you don't, again, traditionally we use urine ketone bodies. And the normal values are highlighted in this slide. And to call this diabetic ketoacidosis, there should be severe ketosis, that is more than 3 millimole per liter ketone body levels. And the use is, it's just like a glucometer, but the strip is different and the meter is different. Sometimes there are combined glucose and ketone meter strips. It's quite handy, and Only disadvantage is these strips are a little bit expensive compared to glucometer strips. Okay, and going through the pathophysiology, it's very important to know the pathophysiology in order to treat properly. So what happens in DK is relative insulin deficiency, that is absolute or no insulin at all, or very little insulin in the body, such as in type 1 patients. But having said that, even patients with type 2 diabetes who are ketosis prone, we categorize as a ketone prone type 2 diabetes, they also can have less amount of insulin, especially during an acute illness. So they are prone for this absolute or relative insulin deficiency. When insulin is not there, body gets hyperglycemia, that is elevated sugar levels, and these sugars are excreted through kidneys and urine, and they drag water and electrolytes, and that causes dehydration and hypovolemia, leading to elevation of our stress hormones. These stress hormones switch the normal metabolism from glucose metabolism into ketone body metabolism, where ketone bodies can be used by our tissues without the presence of insulin. Therefore, as an adaptive mechanism, ketone bodies are produced in excess in the presence of absolute or relative insulin deficiency. These ketone bodies are acidotic, so therefore you get acidosis. So we talked about hyperglycemia, getting ketosis, and getting acidosis. So all three components are fulfilled and the patient gets dehydrated. So these three components are the key components that we should aim in our management, that is insulin deficiency, dehydration and hypovolemia, and ketone bodies. And when talking about dehydration, the fluid deficit of these patients are about like water 100 ml per kg. So if you take about 60 kg patient, it will be about 6 liters of fluid deficit. Management strategy is, there are actually 4 main components. It's fluids, insulin, potassium supplements, and treating the precipitant factor. So fluids, if we take, that is the most important. That's why I have put it as number 1. And restoration fluids, giving adequate fluids would restore the circulatory volume and prevent dehydration. And that also helps to clear some ketones and also keep the electrolytes in balance. And then the number 2 is insulin. And insulin is very important to correct the pathology and also to clear the ketones. In addition, that will look after hyperglycemia as well. And then we need to give potassium, because when we give insulin, there will be an intracellular shift of potassium and patients tend to get hypokalemia. Therefore, potassium should be replaced as indicated. So fluids, insulin, and potassium supplementation. In addition, precipitant factor could be commonly infection, myocardial infarction, CVAs, or even simply in type 1 diabetic patients not taking basal insulin. So you need to address the precipitant factor. So it's easy, 4 components. Now we'll look at knowing, okay, we have to give fluid doesn't mean anything. We need to know exactly how to give, what to give, and when to give. So fluids. If the patient has low blood pressure, that is systolic blood pressure less than 90, we need to give boluses to pick the blood pressure up. So you may give normal saline, 0.9% normal saline, 500 ml over 15 minutes. And if the blood pressure is not picked up, you may repeat the boluses. Once the blood pressure had picked up, or if the patient's blood pressure is more than 90 millimeter mercury, like in our patient, we may start the DKA protocol straight away. Okay, what is this DKA protocol? So regarding fluids, it's mainly normal saline that we give, right? So initially, so it's quite easy. We give 1 liter of normal saline over several hours, right? First 1 liter should be given within 1 hour. The next 1 liter should be given within 2 hours. Next 1 liter within another 2 hours. Next over 4 hours, next over 4 hours, and the last over 6 hours, after which we can switch to maintenance. You may appreciate that there is about 6 liters of normal saline given. Like I said, we are covering the deficit of roughly a 60 kg person. So it's easy to remember. 1 liter we know. So it's over 1 hour, 2 hours, 2 hours, 4 hours, 4 hours and 6 hours. So 1, 2, 2, 4, 4, 6. And after that, it's the maintenance. Having said that, this regime should be tailored according to the health status of the patient, CKD, heart failure, young patient, very young patients, and then pregnant ladies should have altered fluid regimes. You may appreciate that I have put KCl from the second 1 liter. So after the initial 1 liter, you may add KCl according to the potassium level of the patient. Okay, so we have talked about the IV fluids, and let's move to the insulin. I told you first is fluids, number 2 is insulin. How much and when to start? Insulin is given IV, intravenous, that should be soluble insulin, and this insulin we should give it in a fixed rate regime. That is, you don't alter the insulin levels hourly according to the sugar levels. We give a fixed rate. Okay, so now we know we have to give soluble insulin, fixed rate, and how much. It's roughly about 0.1 unit per kg per hour. If it is 60 to 69 kg person, it's 6 units per hour. And the maximum you can give is 150 units per hour. And usually we discourage giving bolus insulin administration like in good old days. You may give a bolus insulin, about like 0.1 kg per dose, bolus, IM or subcut if this soluble insulin infusion is delayed, but usually we don't encourage the bolus insulin administration. Okay, now we talked about fluids and insulin and KCl. KCl administration from the second 1 liter is given according to the baseline potassium levels, and it is very important to add KCl and monitor potassium levels in these patients, and the values are noted in the slide. Okay, going back to my patient, and this patient's capillary sugar is high and ketone bodies came as 4.6, pH 6.8, which is less than 7.3, and bicarb is 5, less than 15. So not with normal potassium. So this diagnosis of DKA can be made with hyperglycemia, ketosis more than 3, and acidosis. So my patient has DKA. And then what am I supposed to do with normal blood pressure? I can straight away go for the DKA protocol, and this is how we managed. So 8 to 9 a.m. first hour, we gave 1 liter of normal saline, if you can follow the chart, and then started on a 6 units per hour insulin, and sugar was 450. Then the second 2 hours, again, so normal saline is given 1 liter over 1 hour, done for the first hour, and then 1 liter over 2 hours. So that is 9 to 11. And I added KCl and continued insulin infusion. So this patient has 2 lines, normal saline plus KCl, and the second line is insulin through 2 cannulas. And I monitor the blood glucose levels. It is very important to monitor hourly blood glucose levels in a patient who is on insulin infusion. Otherwise, there will be consequences. So what am I looking for? Am I going to continue this forever, or what am I looking at? If I monitor, I need to have targets to look at. So what are my targets of giving this regime? So targets are blood glucose drop of 50 milligrams per deciliter per hour, or ketone body drop of 0.5 millimole per liter per hour, or bicarb rise of 3 millimole per liter per hour. So having facilities, we can monitor ketones, but if it is difficult, we may go with blood glucose, and whenever possible to monitor ketones or bicarbs. Provide if we don't achieve these targets, what am I going to do? Then we check the fluids, whether have we given enough fluids? Is the line blocked, or is there something wrong with them? If not, if the fluids are gone very properly in a desired manner, then we need to increase the insulin rate. Why? Because ketones are not being cleared, so we need to give more insulin. Then this is what we did. Insulin, we increased by 1 unit per hour, and then you may appreciate the blood glucose have dropped more than 50 milligrams per deciliter in the next 2 hours, and bicarb has dropped appropriately, roughly about 3 millimole per liter per hour. Bicarb has increased. So now we are happy because we are getting the desired targets per hour, and we are giving the regime very correctly to bring this patient off DKA. Okay, now there's a what are we going to do now? Are we going to go, when are we going to stop this? What are my targets to stop this regime? So treatment goal is to clear the ketones. So clearing of ketone means getting the ketone levels very low. That is, if it is urine, negative ketones, and serum ketones less than 0.6 millimole per liter, and pH of more than 7.3, and patient should be able to eat and drink. Some guidelines use bicarb of 18, but UK latest guidelines don't use bicarb. So it's easy, ketones and pH recovery. But in between, there is this worry. I know most of them, and physicians have this. Now the blood glucose is dropping. What shall I do? Shall I stop insulin? Well, the aim of giving insulin is to clear the ketones. If the ketones are not cleared and if the targets of stopping the treatment has not achieved, then we should not stop insulin. Earlier, we used to continue the same dose of insulin, but maintain the blood glucose levels with giving additional dextrose. Nowadays, the latest guidelines tell that you may consider to halve the insulin dose from what it is now to minimize the risk of hypoglycemia. So what did we do? We actually continued the same dose of insulin, 7 units per hour, because we thought it's adequate clearance of ketones are achieved. And then to prevent hypoglycemia, you need to give an additional 10% dextrose, roughly about 125 ml per hour from a third line. So now my patient has 3 IV cannulas or 3 intravenous lines. One is normal saline plus KZL, second is insulin, third is dextrose. I have seen some people stopping normal saline while giving dextrose. No, that is not the way. We should give all 3 infusions. And you may see that there's a nice drop of increase in bicarb and nicely maintained sugar levels with addition of dextrose, and patient is not getting hypoglycemia. Okay, right. Now when to stop and how to stop. I discussed now that my targets are achieved in this patient. Ketones are cleared, pH has recovered, patient is well eating and drinking. Now how am I to stop this? Am I to stop immediately? Well, it is very important to know that we can't stop IV insulin infusion at all of a sudden. So let the patient eat, and in relation to a meal, we can give subcut soluble insulin 30 minutes, subcut soluble insulin with the meal, and then stop the infusion 30 to 60 minutes after the soluble insulin subcut dose. So we give a subcut dose of soluble insulin, and we may ask the patient to eat and continue IV insulin infusion, and after about 30 to 60 minutes only we stop the infusion. And giving just one subcut insulin is not enough. Then we have to convert the patient into basal bolus regime ideally, that is continuous insulin injections. And what is this basal bolus insulin regime? I think previous speakers have spoken about, so I'm not going into detail. So then the question comes, how much of insulin? Usually we go with the per kg dose, 0.5 per kg, and then 0.5 units per kg insulin. And then you may consider 50% basal and 50% bolus, or sometimes with if somebody prefers, premixed insulin can be used, but we encourage basal bolus regime, especially in type 1 patients. And again, the description of insulin regime, I would skip that. So, key points in DKA management are: diagnosis requires all 3 components of hyperglycemia, ketosis and acidosis. Do not give bicarb for acidosis. This I haven't actually discussed. Usually when the pH is about 6.9, 6.8, some guidelines do talk about giving bicarb. UK guidelines do discourage, and in Sri Lanka we practice not to give bicarb unless the patient is in the ICU requiring inotropes. Giving bicarb actually may cause harm to the patient. Therefore, don't give bicarb, give enough fluids. Giving adequate amount of fluids and insulin will clear off the acidosis, and bicarb levels and pH will automatically rise. Then correct fluid and insulin regime giving, this is very important. Initial fluid followed by insulin, and then upward titration according to the adequate response is important. And when blood glucose is less than 250 milligrams per deciliter, do not stop insulin. You may consider reduction of the insulin rate, or you may start 10% dextrose as required to maintain the sugar levels at around 180 to 250 milligrams per deciliter. When DKA is resolved, give subcut insulin 30 minutes prior to stopping insulin infusion. And if patient is already on or suspected type 1, please do continue basal insulin dose. Do not stop basal insulin if the patient is already on, or if it is suspected type 1, you may start while on the infusion. And then we need to treat underlying precipitant. Okay, going into the second half of my lecture, it's a 60-year-old lady with type 2 diabetes presented with altered consciousness. Family gave a history of diarrheal illness during preceding 1 to 2 weeks, and blood pressure is slightly lowish and capillary blood glucose is high. So the key points in this is like 60 years, she's not very young, and had diabetes, type 2 diabetes, and acute illness also during the last 1 to 2 weeks, and patient is having altered consciousness. Sugars are pretty high. So high sugar levels, we immediately did the basic things like pH, venous blood gas or arterial blood gas, and a ketone body level. So ketone bodies are 0.8, not as high as about more than 3. So it's not definitely severe ketosis. pH is normal 7.3, like not less than 7.3. And bicarb is also 19, not less than 15. So it doesn't fall into DKA category. But there's some alteration, but not very gross anomaly. Same time, because the patient had altered consciousness, we did sodium, and to find that sodium level is 168. It is high, and on examination, we found that patient is severely dehydrated. So, dehydrated patient with hypernatremia and high sugar levels. This should alarm the diagnosis of hyper or smaller hyperglycemic state. So what is the difference between DKA and HHS? DKA, I told that there is absolute deficiency of insulin, whereas in HHS, there is some insulin. So this amount of insulin in patients with HHS is able to switch off the ketone production, so they will not have a lot of ketones, and therefore they are okay not having acidosis. But this little amount of insulin is not enough to tackle the hyperglycemia caused by acute illness and dehydration. Therefore, it's a vicious cycle, hyperglycemia causing osmotic diuresis and then profound dehydration. So because of this dehydration and electrolyte imbalance, patient gets high sodium levels. And because of both, patient gets altered consciousness. And again, like in DKA, the key components are in contrast to DKA, key components are hyperglycemia, and this hyperglycemia is very, very severe. In DKA, it was more than 200, but here it is very high, more than 30 millimole per liter or more than 540 milligram per deciliter. And there is high osmolality, usually more than 320 milliosmoles per liter, and there is no acidosis, unlike DKA. So osmolality, it's sometimes we don't have facilities to measure serum osmolality. So what can we do? We can do like double the sodium level and get glucose levels in millimole per deciliter as well as blood urea. Okay, so in this patient, we talked about these initial investigations, ketones negative, not high, and then when we calculated the osmolality, it is so sodium 168 into 2, 336 6. Obviously, that itself is more than 320. And in addition, if I put 20 millimoles for glucose, and then even without blood urea, you may get the osmolality as 336. So this has high osmolality, high sugar levels, dehydration, and no ketosis. Obviously, this is HHS. Okay. So I talked about diabetes ketoacidosis deficit. Water deficit is roughly about 100 ml per kg. But here, in contrast to that, this condition has very severe water deficit. It's about like 100 to 200 ml per kg. And sometimes patients need about like 10 to 20 liters of water in order to make them recover from this condition. And this has to be kept in mind. Again, fluid regimes can be changed according to the patient conditions, but we need to give fluids. Fluid is the main thing in HHS. So treatment goals are to normalize osmolality and normalize electrolytes, and also then the last comes normalize blood glucose. So we don't pay much attention to blood glucose levels in HHS, although it is high. It's the osmolality, dehydration and electrolytes which are important. Plus, additional to the decay, in addition to what we saw in decay, this condition causes the patient to be highly prone to arterial and venous thrombosis. So we have to pay attention to that, and other complications, like if we are not careful about fluid resuscitation, they may get cerebral edema or central pontine myelinosis. So we have to pay attention, and also foot ulceration. All these three conditions should be addressed during your management. Okay, how do we manage? IV fluids, normal saline, and then another point. This patient has hypernatremia, high sodium levels. So why am I giving normal saline? Because this patient is dehydrated. For a dehydrated patient, normal saline is the fluid of choice. And actually, normal saline is hypotonic compared to patient's serum. And then potassium should be given according to the potassium levels. Like I said, low molecular weight heparin should be given, and precipitant factors should be addressed, like in decay, antibiotics should be given, and insulin. Insulin is number 5 or the last. We usually don't give insulin for these patients, although the sugars are high. It is given only if ketone bodies are more than 1 millimole or there is no response to the treatment that we give. And if we have to give, we give it at a half rate compared to decay, that is 0.05 units per kg per hour. Very, very low dose IV infusion. And fluids, how much? I told the deficit is very high. Therefore, we calculate the deficit roughly 100 to 200 ml per kg, and of that volume, only 50% is given during the 12 hours, and the rest of the 50% we should be given 12 to 24 hours. This is very important if you need to save this patient without complications. When you give the fluids, please note there are few things. Blood glucose will drop even without giving insulin. Although this is a diabetic emergency, we manage with fluids. And initially, sodium will rise actually, and you may wonder why this is, I am giving normal saline and sodium is rising. Should I change this? No, that is expected, and I'll talk about it later in a few slides. And with fluids, osmolality will steadily drop. Targets, like in decay, what are our targets? We should go with targets in these patients. So we monitor hourly sugar levels, O2 hourly, for a drop of roughly 50 to 100 milligrams per deciliter per hour, with a final target of 180 to 250. Some people go for 300 even, not to drop the blood glucose level rapidly. And sodium, a moderate reduction in sodium, 10 millimole per liter per 24 hours is our target. If we exceed, there is a risk of central pontine myelinosis. And we monitor the osmolality, and that should be about 5 millimoles per kg per hour drop. And hypotonic saline. Am I to consider half normal saline? Well, we usually don't consider half normal saline. Like I said, it's normal saline from the very beginning, but we consider it only if we see that there is no drop in osmolality despite adequate fluid replacement with normal saline. So we give a lot of normal saline And after giving adequate amount, if the osmolality is not dropping, then we may consider hypotonic saline. And if the blood glucose level is not dropping with adequate normal saline replacement. So it's easy. And how do we apply to our patient? So we calculated the osmolality and it's high, more than 320. And then this is how we managed. So we gave antibiotics, low molecular weight heparin and IV normal saline. And we estimated the fluid deficit as 12 liters. So of the 12 liters, initial 6 liters, 50% will be given within the initial 12 hours. So that means that roughly 500 ml per hour. That is 1 pint of normal saline per hour, right? Our patient didn't have any major comorbidities, so we continued normal saline. And then you may appreciate the blood glucose level in the third column has dropped very nicely only with fluids, and we haven't given any insulin. But like I said, sodium had increased. 168 had gone up to 174, and we were actually not worried about this because we calculated the sodium level, which should have been there at 8 to 9 am, the initial value, because this is a false value actually what we see. So actual sodium level is masked. That's why we are not very worried about rising sodium levels if we calculate it properly. So actually, if we take, it's not 168, it was 176, the correct sodium level at the beginning. So it's anyway dropping the sodium levels. Most importantly, we check the osmolality. So if we calculate the osmolalities, you may appreciate that the osmolality is steadily dropping. Therefore, we were not concerned of this slight rise in sodium. We continued normal saline fluid regime. So recovery. When we actually go on like this, patient improves, the consciousness improves and everything improves. And after about 6-7 hours, sodium also tends to drop after initial rise. So recovery, correction of electrolytes may take actually about 72 hours and even more. So don't get discouraged, treat continuously and then cover the fluid deficit. Once patient is eating and drinking, if patient is on IV insulin, this could be converted to subcut insulin. And if hydration is poor, you may continue further IV fluids during the additional days of recovery. So key points in HHS are noted down here. First point is diagnosis requires hyperglycemia, high osmolality and absence of ketosis. Adequate fluid resuscitation is the main management in HHS to save the patient. It's about like 12 to 18 liters, 10 to 20 in some patients. And the fluid of choice is normal saline, 0.9% normal saline. Initial rise of sodium should be expected and should not be panicked about it. Like if you are giving the correct fluid regime. And insulin should be only started if ketone bodies are more than 1 millimole per liter at the onset, or if not adequate blood glucose drop is achieved with adequate amount of fluids, and if the osmolality is not dropping with adequate amount of normal saline. And do not give hypotonic saline unless osmolality is not dropping despite normal saline. And then recovery may take longer hours, like 72 hours or more, especially considering the electrolyte imbalance. So just last slide. Why am I stressing on this? Because I'm not sure whether it's clear, the topmost line in blue, continuous line, shows the survival probability of DKA only. And you may see that it's not straight line, but it has some component of mortality. But if you see the green line, green dotted line, which ends up here with hospitalization days of 30, and survival probability is lower than the DKA. So HHS has higher mortality compared to DKA, and you need to identify and diagnose HHS properly, as well as manage it properly. Same time, commonly we see DKAs, and we should not miss DKAs which are fully reversible. Further, although I said HHS 72 hours, it may take longer, correctly managed DKA should resolve within 24 hours. So if your patient is having DKA, not achieving the targets or not resolving DKA after several days, which means that we have missed something or we have not done the DKA protocol properly. Okay, I hope things are a little bit clear, or I'm not sure whether things are again complicated. Whether I have made things complicated. And good luck for the rest of the program. And thank you very much for joining with us.
Thank you very much, Madam, for that very important lecture. So the last topic for the day is how to improve the access to diabetes care in Sri Lanka. So this will be discussed by Dr. Vindhya Kumarapeli, Director of the Directorate of Non-Communicable Diseases, Ministry of Health. She will be joining with us virtually. Over to you, Madam.
I wish someone responds.
Madam, we can see your slides.
Okay, I'll start now. So thank you for the invitation. I'm sorry I am little tight with my schedule, so I'll give a quick update on how to improve access to diabetes care in Sri Lanka. So as you can see, the burden of diabetes in terms of mortality is very high in our country. Actually, overall NCDs are responsible for 83% of all deaths in our country, and diabetes accounts for nearly 9% of the deaths. You can see here when you look at the burden of people living with diabetes, it's nearly 15%. And in addition, when we look at the COVID deaths, also according to the Ministry of Health data, you can see among the deaths due to COVID, diabetes is found to be the highest comorbidity. 53% of them were found to have diabetes. So I would like to present a few activities that our national program is conducting to give access to diabetic patients. So actually this is according to our national policy and the multi-sectoral action plan. So as you can see here, essential NCD medicines are available at the primary care level, which means it's definitely available at secondary and tertiary care level. For example, glycoside and metformin are available at the smallest level hospitals, the primary medical care units, and we have taken a decision to make sure that insulin will also be available at the smallest level hospitals, provided that the pharmaceutical fridge is available in the hospital. So that is one way of improving access to diabetes patients, so that they would get their medicine from the hospital nearest to their home. And in addition, we have actually declared the essential basic investigations for diagnosis, follow-up and complications of diabetes, and that will make sure that the blood investigations as well as urine investigations are available for the patients. They don't have to go to a higher level hospitals, and actually according to the primary healthcare strengthening program, we will be like the patient will not have to go to another place or another hospital. Instead, there are facilities, there are arrangements. The patient's samples, blood samples will be transported if they need more complicated investigation. So that is another point where we have taken a full effort to ensure that the basic investigations are available at the primary care level. It's called actually patient-centered care, where the patient does not have to go to another hospital from primary to secondary or primary to tertiary. Instead, all the medicines and investigations for a diabetic patient would be available at the smallest primary care hospital. That will ensure that the out-of-pocket expenditure is less, and so they will have more and more access to control their condition and also to prevent complications. COVID was actually COVID pandemic affected the NCD patients, including diabetic patients, but we made sure that we have issued guidelines and circulars to make sure that NCD services are maintained. And as you know, in terms of essential medicines for patients with NCDs, including diabetes, we started postal delivery of drugs to their home, so that we made sure that the NCD or diabetic medicines are somehow delivered to the patient, although the hospital clinics were closed due to the COVID pandemic situation and due to the increased workload of the hospitals and the staff to manage COVID patients. You can see here some of the primary medical care units, actually they put a lot of extra effort to make sure that the medicines are delivered to diabetic patients. And you can see here, even in between the COVID waves, according to the health guidelines, whenever possible, medical clinics were conducted so that the patients always had access to NCD medicines. And we actually gave instructions to establish a front desk for the patients. You can see here the blood pressure and blood sugar are monitored even at the lowest level hospital. We provided the digital BP and the glucometers to all the hospitals, including the smallest level primary care hospitals, so that diabetic patients can or could check their sugar level, although the hospitals were not functioning fully due to the COVID pandemic. And actually we instructed our medical officer focal points at the district level to conduct mobile clinics if there were any areas which were any localities that were locked down. So we managed to ensure that diabetic patients had access to essential medicine investigation. And actually, one way of improving access was establishing hotlines at the national level as well as at the district level. Hotlines were established, and trilingual hotlines were established for patients with NCDs, including diabetes, to get any medical advice or any other, to answer any queries in relation to their diabetic condition. And so when we look at the medical clinics, actually we have taken initiatives to make sure that the diabetic patients are screened annually for their complications as well as for other NCDs. So guidelines are there. So this will make sure they get the best care, best follow-up. And I would also like to mention that especially at the primary care, the personal medical records were introduced. You can see the personal medical record here. They were introduced, and some of the medical clinics are issuing this so that to ensure that there is continuity of care for diabetic patients and other NCD patients. And we also recommended to introduce cardiovascular risk assessment for patients so that the risk of getting a cardiovascular event in the next 10 years would be assessed, and that is also very beneficial for the diabetic patients. And Ministry of Health also issued guidelines to make sure that the follow-up is done in a very systematic manner. Follow-up is very essential for the monitoring of their sugar level or blood pressure level is very important, as you all know. So we have issued guidelines so that some patients are monitored every month, and there may be some patients who need not be monitored monthly. So there is a guideline issued by the Ministry of Health so that this will help us to reduce the overcrowding at the medical clinics and ensure that the follow-up is a quality care is given to at the medical consultations. So these are some of the initiatives that we have taken to ensure that they have access to good quality care. In addition, we have started training medical officers and nursing officers, especially the medical officers, nursing officers, public health nursing officers on diabetic foot care. These were done online due to the COVID pandemic situation. And then we are planning to start to train medical officers for screening for diabetic retinopathy. So in terms of diabetes, you all know very well the food care and retinopathic screening are important from the national level with the help of the professional colleges. We are taking all these initiatives to ensure that they get a very good quality care once they are diagnosed. As you all know, lifestyle modification is equally important. So when we look at the lifestyle modification, the clinics are very busy, overcrowded. I don't think it's practical to ask the medical officers at the clinics who are following up diabetic patients to offer them lifestyle modification. Although it's the correct method, and I'm sure you know that while taking the medication prescribed, it's equally important to follow lifestyle guidelines. I am sure you must have heard those during the previous presentation. So one option that we have is our Healthy Lifestyle Center. So these healthy lifestyle centers are actually scattered throughout the country, mostly at the primary care level. And if you are interested, you can access their location from our NCD unit website. And as they are mainly located at the primary care level and at the same premises as the medical clinic, it is very beneficial if you refer the patients to the Healthy Lifestyle Center for lifestyle modification counseling. So in terms of now, you all very well know that there are 4 main modifiable risk factors for NCD: unhealthy diet, physical inactivity, tobacco and alcohol. So in terms of healthy diet, we have a package. We have a training module, and we have trained the primary healthcare doctors, nurses on healthy diet, promotion of a healthy diet. Now it's more formalized. We have published a training manual. So our main, just to brief you, our main target is to make sure that they consume less salt, less sugar and zero trans fat. So the recommendations from our national program is to limit salt intake to less than 1 teaspoon per day per person. They limit the sugar intake to less than 6 teaspoonfuls per person per day and completely avoid trans fat. So the diabetic patients may have specific more general advice, and these are actually for like very basic advice. So we have an advanced training module for 8 non-communicable diseases. So diabetes has a separate chapter, and that was actually prepared in collaboration with the professional colleges. So the diabetes chapter gives the medical officers more specific information to be given to a diabetic patient in terms of diet. The menus, healthy menus are given, and lot of information are given there. Then what about physical activity? So we have trained our staff, the medical officers, nursing officers, public health nursing officers, mainly at the primary care level, who are working at our healthy lifestyle centers on how to promote physical activity. So this is a general recommendation what I have shown here in the screen. But as I mentioned earlier, for 8 NCDs including diabetes, we have a specific guideline. If you follow the diabetes chapter of the guideline, it gives specific physical activity for diabetic patients. So it's the same book which gives the dietary and physical activity training. So these will be available online very soon. So and we plan to train all our medical officers at the primary care about this specific disease specific dietary and physical activity guideline. So the motto would be, let's move more, every move counts, because you really don't, it's good if you can have a structured exercise program, but just the general promotion of physical activity itself will motivate them to engage in more and more active life. tobacco, of course, again, we have a brief intervention for tobacco cessation. We train, we have a package, we have videos, and we train our medical officers as well as other staff, because these are very brief interventions. So any diabetic patient who is a smoker or any tobacco chewer, they can go to the healthy lifestyle center or the medical clinic. MO should actually refer them to the healthy lifestyle center so that they will be given help to quit. Because we have trained our staff and have guided, instructed them to establish a quitting clinic at Healthy Lifestyle Center. So our motto is again, quitters are winners. For diabetic patients, they should quit smoking, and we can offer them help how to quit smoking and as well as alcohol at our Healthy Lifestyle Center, where we have the quitting clinic. So finally, I would like to mention that we have a NCD training platform. All the material in terms of especially the lifestyle modification material, everything is in our NCD training platform, and we are actually developing more and more online videos, online modules. Because of the COVID pandemic, it's very difficult to have in-person training. So you are most welcome, because it's free access. You can access our website and the NCD website, and you can learn more about lifestyle related management of diabetic patients through our website. So thank you very much. That is about the national program on improving access to diabetic patients.
Thank you very much, madam. Now I would like to invite Dr. Chandrika Subhasinghe, consultant endocrinologist at the District General Hospital, Chilao, and secretary of the Sri Lanka Diabetes Federation, to deliver the vote of thanks.
Thank you. So we have come to the end of another very fruitful program. So every year, Sri Lanka Diabetes Federation, the public arm of Sri Lanka College of Endocrinologists, conduct diabetes updates for doctors as well for nurses. So this is one of major ways we can improve the diabetes care in Sri Lanka. So we hope you got a lot of new knowledge through this diabetes update, and you will use this knowledge for future care for our diabetes patients. And I would like to thank all the speakers for their very comprehensive talks on diabetes care, updating our doctors. As well, I would like to thank the organizers, the chairman, Sri Lanka Diabetes Federation, Dr. Manilka Subanatilaka, President, Sri Lanka College of Endocrinologists, Dr. Chaminda Garusinghe, as well the organizing committee, Dr. Gauri Ratnayaka, consultant endocrinologist, Dr. Dayakshi, as well the senior registrars in endocrinology, Dr. Preeti, Dr. Pavani, Supun, Umesha, and also the compeers, Dr. Neomal and Dr. Pavani, for joining with us to make this event a success, and also the audiovisual team and the sponsors about nutrition, and all the other office team to make this event success. Thank you very much. And we will be conducting the diabetes update for nursing officers from 1 p.m. onwards. We hope the nursing officers will join with us in the afternoon. Thank you.